Because you went right across. You didn't choose this patient? Do you end up using her at all?
No, we didn't use that because we only removed the posterior arch and we left the joints. So we didn't see any need to use that.
The next, please. So this is a female patient born 1980, complaint of pain in the area of the left hemiplex, radiating to the left flank. And for this reason, and this was especially during straining and during vibration sensation. So kidney disease was ruled out by this patient. And due to the persisting symptoms, image was performed. And she also went, this is at the thoracic level. I think it's T10. And you see cystic lesion in her foramen. And she went targeted infiltration. Unfortunately, it was not positive. So any diagnosis for this patient? Okay. What else? We are coming to this point. Yeah, next slide. So this patient went for a surgical resection at T10 level. It was performed modified costal prostatectomy at T10 with rhizotomy. The histology revealed it's a talus cyst. So you always have to think of diagnosis. And post-operative, she did quite well. There was no reason. Next slide. Next slide. Next one. Okay, this is a very interesting case. I added this case from my clinic because I think most of us do not work in university hospitals or hospitals with neurologists in the hospital. So this is a guy, middle age, in his 50s. He had a past history of L4, L5 decompression. It was around 20 years back. And then he goes to the forest and does some wood cutting with the axe. And he notices that there is paraparesis of his leg. He goes home, and then the paraparesis increases. For this reason, he comes to the hospital. Imaging is performed. Next, another slide. Another slide. I think again. So I think I have not included the proper image. So an MRI of the lumbar spine was done, and we have seen lumbar stenosis L2, 3 and L3, 4, and L4 micronuclear stenosis. The patient presented with paraparesis, but it was more distal than the proximal. Distal was grade 2, and proximal was around 4 minus. So here, after this image, what particular about this patient was, he was also pre-operatively and post-operatively he got delirium. So a proper history was also not possible. We tried to trace his medical history from his previous surgery, which was also not possible, and he had no one, so there was a lack of proper medical examination which we could compare. So we did the compression at L2, L3, L3, and 4. So post-operatively, he did not improve it, and actually his paraparesis worsened, and then it was ascending, and in the ICU, because of the delirium, he was post-operatively in the ICU, and he developed also weakness in his upper limbs. And we performed. Can we go back? In the no. So in the cervical MRI, we have seen foramen stenosis at C5, 6, and C4 and 5. But because it was not clinically, it was not correlating with the images. And what happened also that the patient in the ICU developed facial paresis and abducens paresis. So everything was not matching together with the examination. We performed the next slide because of the facial paresis. Imaging of the cranium was done, CT and MRI. There was an ischemic stroke was ruled out, thrombosis was ruled out, We did not find anything in the cranial side. Neurologists, we don't have neurologists in our hospital. So a neurologist came and examined him. He was also not very much sure what was happening. So we gave the patient cortisone. So there was slight improvement of his facial paresis, but he developed abducens paresis also. So at the end of the day, to bring the whole story short, the patient had actually Guillain-Barré syndrome, and it was diagnosed by a neurologist. He was transferred to a tertiary care where they performed LP, and it was also not only Guillain-Barré, it was a rare form of Guillain-Barré syndrome, Miller-Fisher syndrome. So actually, this is an autoimmune disease. In Miller-Fisher is like you don't have the reflexes, cranial nerves, the nerves, cranial nerves are involved, and the treatment is plasmapheresis. And lesson to learn from here is, I always say that over years of practice as neurosurgeons, we become specialized idiots, sorry for the word. So we have to think always out of the box. If the imaging is not correlating with the clinic, you always have to think of other diseases and do not waste time. Bring the neurologist, do the necessary things, because in our case, the patient actually did not improve because there was a delay in the diagnosis. Next case. Yeah.
I just have a question because I think this is also a case which it's almost same like the past case. And you have mentioned in the US you do the EMG. It just occurred to me that the EMG, the results are only positive after 6 weeks. Correct me if I'm wrong. I think you need to have a time period of 6 weeks in order to make a positive diagnosis with an EMG. But
many, it has to evolve to the point where the EM.
Yeah.
So for many neuropathologies, the process has to evolve to the point where that technique can pick it up. So many times this is a diagnosis that's clinical in its base rather than purely electrodiagnostic. But if this was going on quite a while beforehand, the EMG may have shown some degree of polyneuropathy and no evidence of radiculopathy, which sometimes we do see. Completely different case, but a patient with a diabetic polyneuropathy, that'll show up as a subtle finding. If it says there is an absence of radiculopathy, then certainly surgery, something we try to avoid those instances, but may have been a non-diagnostic study.
Last case. So this is a male patient in his mid-40s. He presented paraparesis, and on the imaging, which we see with contrast to spinal lesion, enhancing spinal lesions. And next slide. So the patient underwent a surgical resection of the 2 lesions under electrophysiological monitoring, and the histology showed the cervical area was ependymoma and the thoracic area was the meningioma. So it's very, very rare, 2 different entities in a single patient. So unfortunately, the patient did not really make a full surgical intervention. So this was my last case. Thank you so much.
thank you.
Thank you so much. We're going to move on to the next talk. Establishing neurosurgery training program in Kisumu by Dr. Kim and Dr. Oluna. Thank you.
Yeah, okay. So So this is a talk I'm really passionate about. It's a talk which has evolved over the past years. We've talked so much about it, and it's good because some members of the institutions, one of the stakeholders, are here represented, and this is basically also the dream, the vision that we had when we started the Kisumu Neuroscience Initiative. Yeah, David is also here. I can introduce yourself. I think you don't need any introduction.
I introduced myself. I asked Victor. Victor is very good at Vic is very good at David Oluchulu, yeah. I occasionally visit Kisumu. I'm based in Nairobi, neurological surgeon. This issue of Kisumu Neuroscience Initiative is part and parcel close to our hearts. We were trying to do some things earlier on before selection balance 2007. At the time that Tim and Vic and Tom were all trying to get these things done, we were also trying to get things locally. So I wear different hats, despite being a neurosurgeon in Nairobi. I also happen to be on the board at the work with Vic Hospital. So what happens is, if there are things that one can't push, I have got a direct ear to His Excellency the Governor. I also give instructions to the CEO. So in case you want anything done specifically, please answer.
Okay, then we can move on to the next slide.
So as we're going to start working on your wish list of everything. So
We already have
mentioned it, so
the microscope.
we'll feel.
All right. So I think Kisumu as a city is kind of underrated, you know, and it's when we started the initiative and when I spoke to David and other colleagues that also it occurred to me how Kisumu in the region is really at a strategic place. And it's a region with a lot of potential and a lot of promise. And it's, you know, all the areas like Uganda, Tanzania, I'm not sure, the last time I checked, Uganda has like less than 5 neurosurgeons. Tanzania also less than 5. I've never heard of any neurosurgeon from Congo. I know there's one in Kigali or 2. 5 or 6. And Burundi, I don't know. I'm not sure whether, yeah. So, and then you also have Sudan, South Sudan, and Ethiopia. And Kisumu is right here. Just, you know, near Uganda, near Rwanda, and near Tanzania. So it's actually, if you have an emergency in the eastern part of Congo, you reach Kisumu much. Okay, you can go to Kampala, but Kisumu is also really very much reachable. So Kisumu is a door to a huge underserved region, neurosurgically underserved region with a population of exceeding 100 million. The infrastructure is developed really well. There's an international airport, which is yet to reach full capacity, I think. And we're really grateful for our committed county government and for the hospital, which is also really committed. And there's also the Maseno University, which has a medical faculty. And I don't know how many students they produce in a year, but it's also significant, you know? Yeah, so, and of course, the existing efforts through the Kisumu Neuroscience Initiative. The next slide, please. So this is a table I got from Robert's paper, which he's still working on. These are the cases we've done so far since 2017. And what surprised me most when I came, you know, I thought maybe neurosurgery, I thought maybe cranial surgery was on the forefront. I was really surprised to see that we have a lot of the spinal cases. They make almost, from what I feel, almost 60–70% of the cases. And most of these cases are women, middle-aged, old, and also old women. And if you look at the social structure, the women in this area work more than the men. I'm looking for contradictions, yeah. You know,
with the neurosurgery.
so I think, you know, and so if from the cases I've seen, if the woman of the house has a spine problem and she can no longer go to the market, she can no longer work, then the whole house suffers under that. So I think this is a significant problem, you know. Next slide, please. So we were asked last time, we spoke with the CEO, he asked us to make a proposal. And we wanted to make that proposal today in this symposium. And we would like to propose a COSEXA-based training program executed by the Kisumu Neuroscience Initiative with a goal to train 1 to 2 FCS residents. You know, the training takes 4 years, but once we get into the cycles, we can have 2 residents, 1 to 2 residents trained per year. So these are the stakeholders, you know, the hospital, the representatives are there, Kisumu Neuroscience Initiative, they're also there. I haven't seen anybody from Maseno University, but it's okay, me is a person, yeah, of course, yeah. And forgot that we always associated with the hospital, not the university. So so these are the stakeholders, and the idea is to have COSEXA as the umbrella of the whole training program. Next slide, please. And this is the structure that we thought about and discussed. The hospital, as a stakeholder, as I say, the university and the initiative. So the hospital has to obtain COSEXA accreditation, you know, in order to be able to train neuro residents. The hospital has to guarantee a capacity of 12 neurocamps per year. That's what we also discussed earlier on, which I found really nice because this was a talk we prepared. There has to be a job guarantee for the FCS residents. We propose that they pay for the fees of the residents, which is about $1,700 for the MCS and $2,300 for the dollars for the FCS, and employment of a local Kisumu Neuroscience coordinator. That's the work that Cosmos has been doing. Unfortunately, it's not here today because it's really the engine of the program. Like he coordinates everything, makes sure the communication works among all the colleagues. Then the university could play the role of identifying and grooming potential residents. With the university, we could have an affiliation for scientific research and publications, and this is what COSEXA requires as this is the structure of the program. The residents have to do the MCS, which is a COSEXA training, 2-year surgical training program. We will propose that there's a pre-approval by the Kisumu Neuroscience Initiative after an oral interview. You know, it's good to just gauge the commitment and to know where we're going with the residents, yeah, because this is it's an investment of 4 years, time investment for the colleagues involved. Then the application, of course, for the FCS COSEXA, and the program will be then a full training program executed by the initiative. We could have from the initiative in year 1 to 3 oral examinations, year 4 MCQ exams based on on the boards interviews, and of course there's a COSEXA examination, which is the 2 MC multiple choice and 2 oral exams. And this is part of this was touched on today morning, what the role of the initiative could be, because we need to make this sustainable. It has to run all throughout the year. So one of the structure which we will need is a core team with maybe 7 to 8 consultants, and a program team with 7 to 10 consultants. who are based worldwide. They don't need to be in Kisumu. So these teams can grow according to, according to what capacity is required. So we'll need a program director and a deputy director in line with the COSEXA guidelines. And the initiative will then be responsible for coordinating and organizing the 12 camps in a year, training of the residents, and examination during the neuro camps. The idea is that if we have 12 neurosurgeons who are ready to hold a 2-week camp every month, then we could have every month a 2-week camp, 2-week training for the residents, and that will provide some sustainability, And if the consultant has the camp, let's say in January, then he could also have a 1-month virtual on-call status as a consultant, so that the residents who are being trained always have somebody to speak to when they're on call, to virtually to discuss the cases and to organize the treatment methods. And the KNI issue will also establish a curriculum. Also establish the IT infrastructure needed for Zoom. This is not, this is something that can be done. It's not something which is cost intensive. And of course, collection of data and analysis and publication, and that's already begun. So this is just a rough idea of our proposal. Like I said, 3 stakeholders. Everybody has to bring in something. The university has to bring in something. The hospital has to bring in something, and the initiative and the weight, I think, lies on the hospital and of course the initiative. So I don't know.
I think Tim set me up when he's saying that the weight lies on the hospital. So I kind of collapse under the weight of that. In a nutshell, that's what we want to be able to do. As it stands, we actually have some trainees currently. We've got somebody in Uganda, we've got somebody in Egypt, and being sponsored by and there's one other. So at least we've got 3 on the wings. So God willing, in the next 4 years, we shall have that as a capacity. We have been negotiating with the hospital itself to have these working from Maseno University, but to have a salary for a consultant from Jaramogi itself. So that's also will end up in the pool. One of our other younger jurors, Khalifa Tifata, who is currently at God Wings. Sorry, I'll have to use your name in bad light. If you look at him carefully, he actually has red underpants and he's got S on his chest. He tends to kind of fly. So sometimes he's in Kisumu, sometimes he's in Mombasa, then occasionally he's doing angiograms at Jomo. So he's all over the place. So we are using him, and I think he's one of the people who will be helping us to get things going because he's got a lot of steam at the moment. But as it is, that nutshell, prior to COVID, we had hoped to have had the beginning of the training program by 2000. This is only 3 years late. COVID set us back by 2 years. But with that as it may, all those things are in position. And the other thing that the CEO had asked for, if any of our colleagues from across the water wish to be popping off to the Masai Mara every kind of 6 weeks for a week, they can come here for 6 months, and then every 6 weeks to go to the Mara and let some animals see them, and they can give us a stint for about 6 months to be able to keep this cycle going. But all in all, it's ambitious. Our colleagues across at Eldoret, and how many strong are they now? 13?
Yeah, 6.
Six neurosurgeons, and they've been taking a lot of our work from us. So we want to try and catch up in that respect. In terms of location, we cover all the way up towards Kisii, as you mentioned, all the way across the lake. So there is an opportunity for us to do a lot more. I think I'll just say that for now. If there's something more you want to add.
Yeah. So I think with my German mind, Kenyan but German influence, I thought maybe we could within this symposium, we could make some concrete decisions. I think something which can be done already, because we have COSEXA members in the audience, is to get the program director and the deputy director already appointed. From us, from the initiative, if there are any colleagues who are interested in these two positions, because this is a COSEXA requirement that the program has to have a program director and a deputy director. And I'm not a COSEXA member, so I'll need, I think, 2 recommendation letters from a COSEXA member in case I'm to join any of those positions, or any of us. I don't know, Dr. Lee, are you COSEXA? Or, yeah. Any COSEXA, Ben? Yeah. Yeah, so we need endorsements to become members. Yeah. You also COSEXA member?
But you can get 2 reference letters.
2 reference letters to become a member. Yeah, so yeah, from 2 different members. Okay, is there any other COSEXA member in? Oh yeah, then we have 4 letters. Yeah, wonderful. Okay, good. Then one thing, I think we spoke about this. I don't know about the virtual on call. This was also just a suggestion. I don't know if Rob, you spoke about it today earlier on. If there are any other ideas to expound on?
So to address that directly, I think that it was just that nothing really came that was really good from COVID, except for the ability to virtually interact. And this meeting is an example where something like Teams has really become an excellent resource. Teams, Zoom, or what have you. So yeah, I think that because that technology is very inexpensive and exists already, and Wi-Fi is relatively and generally available, I think that would be an excellent way to start. I know that colleagues of mine from Cornell have established a Zoom. I mean, I'm not going to mention the various brands, but whatever modality one selects gets agreed upon, and the group of surgeons utilize it. I think it's very reasonable. Just being sensitive to the time, what time it is in Germany compared to what time it is in the United States, as opposed to Kisumu. I think that's really the main limiting factor. But I think most of us would be happy to participate in some sort of endeavor of that sort for sure.
Just to Rob's point, the first step is getting internet at the hospital. So we have a telemedicine consult service set up in the West Indies already, where we take call over here. And we have a cloud-based imaging software we use. So for example, as a resident on call, as CAT scan's done, they upload to the cloud-based, they will log in and everything. I can see it on my phone. So they'll call me like whatever. It's not that frequent. They call me 1 a.m., 2 a.m., whatever it is. I can do the CAT scan on my phone, upload it, and we do a WhatsApp FaceTime. Because everyone has WhatsApp. So you don't need to invest in Zoom or anything like that. The alternative is the resident can take a video of the CAT scan. Just send it over WhatsApp. That way you don't need to have it reliable data plan. So it can be done very economically and cheaply. It's just a matter of the basic requirements, at least some sort of Wi-Fi or anything. But this can be, I can organize this over a night, maybe a 12-month schedule, one of us per month. And all you do is everyone has WhatsApp, or we use our cloud-based server if you want, which I'll gladly donate. We already pay subscription service and as many users as I want. So we already have this up and running. It's not very hard. But the time difference. That's what you do 1 month at a time, not 12 months.
Just to follow up on what you said, in the lecture hall at the room, you actually got a set aside Zoom facility or internet facility where video conferencing is done. It's done by another initiative, and it's up and running. So the Wi-Fi there is actually quite strong, and it is possible. You've got conference that you want to do or case discussions is easy enough. So that actually exists. So that the bit that you have to do isn't that much more.
So on the internet, I mean, the Kenyan internet is actually quite strong and quite good. We've already been communicating on WhatsApp prior to the camps. So that's already there. So I think the next step is one of the things that I also wanted to suggest is, we will have a list all the neurosurgeons who are interested in doing the virtual on-calls. We'll collect your contacts, your phone number, and then I also wanted to ask if there are any volunteers for the program director, deputy director, and if you could also just stamp that today, and we know this is the guy we're going to, because you'll have to organize, then he'll be coordinating everything, and of course, also it's a requirement of COSEXA.
Can I ask a question?
For the non-Kenyan surgeons that may want to be involved at any level in this, do we need to be licensed permanently in Kenya? Because at this point, we're temporarily licensed every time we come. Is it difficult to do? Is it something that would be required if we're backing them up on call?
That's an excellent question. Actually, you took the words out of my mouth with that part. And also, what would it require in terms of our appointment within whatever structure you develop? And does it require us to apply to be affiliates of COSEXA or to be faculty members? Is that something that needs to be considered as well?
So I don't have the membership, but I licensed in Kenya. It's a little bit of a process, but definitely can be done. I think instead of getting the temporary licenses every time, is what I used to do. I just last year got my permanent licensure, which is something definitely done. You have to meet pretty much you apply, and then there's a meeting with the board. That this is kind of an all face-to-face, each at the time because of COVID, we did it over Zoom. So for me, I didn't have to travel here to do it. I don't know if they still require me to actually be there in person or not. But when I did it, it was over Zoom. So it was pretty straightforward. And then once you got that, you were able to get the license.
Just another question regarding that. Obviously, those faculty members that may be politically connected, obviously, if there is desire for this initiative, I think that maybe the folks on the board would be apt to make the process reasonable for the folks that maybe can't come to Kenya to do that interview, make allowances for that purpose. A thought. And just one question regarding the COSEXA process. Would these trainees be full-time in Kisumu, or would they spend time, say, in other COSEXA sites, whether it be locally in country or in any of the sites that you referenced?
Taking on the last question first. Yes. COSEXA probably they don't stay in one institution. You do rotate depending on the number of years that they're in training. There are some slots that are available for them to go abroad. It was unfortunate he didn't go abroad because of COVID, but he went virtually. So we're going to try and make sure he goes down. I mean, after his time. And Ben what's here? Ben, that one. Not Ben. We're talking about Ben Ohanga. Yes, about. Ben went to India. Some of them went to Turkey. Some have been to Japan. So it is possible. It's actually put in the system. And the first question in terms of motivation, I think we have the ear of the current government in Kisumu, and he's very keen to make sure these things work. And he's got ears of people further up. So in terms of regulatory situations, all that can be modified.
Have a motion.
Yeah.
Oh, dear. I think that the person who's the program director has to be the person on the ground. Okay. It's very hard to run something without a person on the ground. I motion that Dr. Lee will be the program director. If it's agreeable.
There'll be some steps for him to be able to have that back.
Well, he needs to take the steps, but that's my motion. If it's agreeable.
Everyone else step forward, he steps back. You know?
He's agreeable, so we have a comment, sir.
With the understanding that it's a COSEXA umbrella, I think there might be some requirements for COSEXA that are required of that program director. And I think one of them probably, so we had mentioned that you need to be part of that membership with COSEXA.
Possible to. So we have a program director.
Motion second.
Motion second against that, so we have a program director. So how about I would propose at the same time, a deputy program director. So I want to propose that we have Tim as our deputy program director, whatever stuff he has to get, he'll also do it. You second, somebody second, done again, done, okay,
You
Tim.
have to be
Let me just mention one thing. You know, there's so many challenges, and this is not. I think also the COSEXA requirements, and you know, this posts, we are not able to do everything by the book. You know, it's not like I don't think the program director has to be employed by the. That's my thinking, that the employment has to come from the hospital. You know, so we need to also do things a little bit outside the box in order to get the program really sustainable and running. Yeah, for the start. And then to the residents, I mean, the proposal is job guarantee for the residents, you know, and you know, the problem is if some of the requirements are not met, or let me just say all the requirements, then there's no way it can work out. If the residents are not guaranteed a 4-year, they don't get a 4-year contract, you know, we can't do that. Yeah, so that's why I think it's really important for all the stakeholders. And the list for, I think I'll just have a list going around for the colleagues who are interested in doing, like I said, the virtual on-calls and who feel confident enough, not now, but maybe in 1 or 2 years, to hold their own camps for 2 weeks as part of the program.
That just one more motion is someone to be in charge of the virtual apps, the virtual component of this. So I'm going to propose that we have Dr. Galler in charge of getting everything together. So between Dr. Galler, yourself, and Dr. Lee, I think starting with a small group of people, and then they will inform us on what we will inform us on where your soldiers were ready.
Okay, all right. So the first things first, we need the letters today. That's something that I'll just type it, print it out for COSEXA, for Lee and I, and then thank you so much from Ben. And there's one more question.
So I'll accept the charge as long as you can create it as a co-director and I can drag Darren into it. He has a lot of technology that I think rather than recreating the wheel, the cloud-based server is phenomenal. First of all, he's so beautifully dressed. Who doesn't want to look at him virtually anywhere? Very important, but yeah, that would be.
You accept.
No pressure, no pressure.
So if this doesn't move forward, we don't move to blame. So, yeah.
Wow, so I'm not the only
Comments behind us.
And thank you very much. For COSEXA, the requirement usually is the site program director is domiciled in the hospital. So Lee would be a good choice, but I'm just wondering the interaction between the university and the college, because COSEXA is a collegiate training. And the university also has its programs, which they develop for various disciplines, parts of medicine programs. So I don't know how Maseno would be able to gel with COSEXA. Our program director for general surgery was Dr. Peter. And it was a Bondi, then Dr. Peter was doing the coordination, but at some point he eased off a bit because there was some sort of conflict between his interaction with COSEXA and Marcelo. So he didn't want to be like the face of COSEXA, yet he's a faculty in Marcelo. That was my first concern. Second concern is there's anesthesia in.
Well, it falls under,
Because for you to have
the referral hospital.
safe surgical training, anesthesia is indispensable.
Yeah, okay, I didn't highlight that because it falls it falls under the hospital, like it's definitely inside. Yeah.
Fortunately, the hospital also has been accredited for collegiate training in anesthesia.
Yeah.
That's the problem there.
Yes, once the question is the idea, okay, that's why I stand corrected. The idea about Maseno was just to identify and groom the undergrads who are, to bring forth the name so that we train from locals. We don't have to take people from Nairobi or wherever, so we can get our residents from Maseno when they
have been very supportive.
Yeah.
In fact, even Dr. Lee here, Dr. Peter, the faculty from Maseno, they support the residents for COSEXA, but they don't want to be like on the forefront. So I don't know how Lee will be the program director of COSEXA, yet is also faculty in itself. That is what I'm trying to understand.
Thank you for that point. One of the things that we have to try and do is to tread carefully, not to explode too many minds, not mindless. One of the advantages that we have is Professor Gendo is the dean, he's the dean. And the dean of Maseno, he's actually a COSEXA supporter and is within that. So he actually wears two hats. So we'll discuss with him in terms of how we'll be able to walk this line and not upset too many cards. So point taken, we'll try and negotiate that.
Thank you for the presentation. Just a few points about COSEXA. I think the COSEXA neurosurgery program is now about 10 years old. First graduates, I think, was Bore and Kitia, just gone on. Initially, the training site was only KNH, but I think in the country now there are 4 accredited training sites. And I think this year NTRH and KU are going to be accredited and apply also for inspection could well be accredited. What's happening now is because there are so many more training sites, each site is picking their own residents according to the numbers allowed by COSEXA and by the Medical Council. Also, what is happening is that you find that each site has got its own strengths, its own weaknesses. You might find the site is able to train very well in trauma and pediatrics, but maybe lack the ability to train in microsurgery. So I think from this year, you'll find that there will be like a local coordinator for COSEXA, so that there will be one common interview for all the candidates, and then now they'll be picked into the various sites. And as much as they're going to be rotating camps and so on, I think what happens currently and what has been happening is that the residents here will tell us is that people move from site to site. They can spend 6 months to 1 year to 2 years on different sites, training based on the needs and the strengths of each site. And I think there's also there's a provision for a lot of country rotation. Maybe when you need more microsurgical experience or more specialized experience. I don't know if that is part of your plan.
Yeah, just shortly before. The reason I highlighted the spinal cases, I think in Kisumu, we are really strong on spine. And I think that's probably going to be, that's going to be our main field, I think, to start off before we grow we go to the level where you can also do, we have a microscope and can do much more complex cases. So the starting point will really be spine, I think.
All right, we'll stop there for now. Thank you so much, Dr. Lunyang, Dr. Tim. We're going to move on to Dr. Karras. After Dr. Karras' talk, we'll have to take a lunch break. It's going to be in the lunch is going to be in the restaurant right on this floor. So everyone who's in attendance, you're welcome to go there and eat. That's already provided with your registration.
Okay, thanks. The next two talks will be a little bit about an update in the technology in neurosurgery. I'll be talking about spinal cord stimulation. Dr. Lobel will be talking about other technologies in the operating room. And spinal cord stimulation is something that I've been talking to some of the physicians here about, and it's not being utilized very much in Kenya, if at all. In the United States, the same applies to some extent in the neurosurgery world. It's something that's used more by our pain management specialists, but it has grown significantly within the neurosurgery world. But some of the technologies have changed. Some of the surgical techniques require surgical training. And so this is part of my practice that has grown significantly over the years. So we see some of the technological aspects very frequently and some of the pitfalls very frequently. But most importantly for neurosurgeons and for orthopedic surgeons who are doing spine, it is good to know when spinal cord stimulation can and should not be used. And so we'll be talking about some of the diagnoses where spinal cord stimulation is approved by the FDA in the United States, some of the diagnoses that it's currently being researched in, and then, like I say, just some of the technical aspects of it, just to start the conversation here, as it can, if the cost comes down over the years as the technology becomes more normalized, it can be utilized, I think, quite effectively here. Okay, so go to the next slide. We talked a lot in the previous presentations about all the different ways different pathologies can cause issues with the nerves in the spine. There are intradural tumors, neurofibromas, schwannomas. There are disc herniations, of course, facet arthropathy. There's an infinite number of ways that the spine can cause pain. Some of these are dangerous and need to be addressed. Some of them are not dangerous, but are painful and functionally limiting. And it is those not dangerous, but painful and functionally limiting pathologies where spinal cord stimulation becomes useful. And that is the majority of the diagnoses that we see in day-to-day practice in neurosurgery. So I'll just go through a few slides here of different pathologies that may or may not be addressed by stimulation. Multi-level spondylosis. I can see some artifact here. There's already screws. There's adjacent segment disease with some ligamentous hypertrophy and moderate stenosis. If I decide of the three ways we can treat the spine, decompression, fusion, and stimulation, the three surgical ways to treat the spine, if I decide to do a fusion of the next level, I may wonder whether this level will need it in the future. I may wonder whether these levels will need it. I may wonder in the next surgery whether I should do all those levels and apply some lordosis, do a deformity surgery, many options, none of which are exceedingly predictable. So once we start operating on the spine, we address significant issues, but we may cause significant issues in the future. Let's go to the next slide. Look, more multi-level spondylosis, previous fusion, some mild foraminal stenosis. Here we have a little bit of a disc herniation, but the canal is widely patent. We're not seeing anything dangerous, but we are seeing issues that can be painful. Is it predictable that if we decompress the foramen or the canal or remove the disc herniation, that the pain will reduce? It's not predictable. We have varying literature on it. And one important point to remember in all literature, particularly spine literature, is that the majority of our patients would never meet the inclusion criteria for the studies that are done on spine. And so if I have 18 to 65-year-old healthy, non-diabetic, non-hypertensive patients, and we do an L4-5 discectomy and the radiculopathy improves 80% of the time, I can quote my patients that 80% of the time a discectomy will reduce your pain. But that patient wouldn't have been included in that study because my patient has diabetes, they have hypertension, they smoke, they're obese, there are other issues that prevent them from being even in the study. So for us, it is very difficult to predict who will recover and who won't, and to what degree, if they have pain control, that the pain control will allow them to function. Because bringing pain from 8 out of 10 to 5 out of 10 may be useful subjectively, but it may not be useful functionally. Okay, same thing here, a little more stenosis, central canal, ligamentous hypertrophy, disc herniations. No pain, I'm sorry, no neurologic deficit, but significant pain. Let's go to the next slide. Widely patent canal, multi-level disc degeneration, even some edema, small foraminal stenosis. This one, we have a broken screw, but on flexion extension, no instability. So previous ACDF, I can see some fusion here, and there's a broken screw or loosening hardware. Facet hypertrophy, gapping of the facets, and some stenosis. Let's go to the next slide. Facet arthropathy, gapping of the facets, widely patent canal, foraminal stenosis, a large previous fixation fusion with broken rods bilaterally. On flexion extension, it's stable. So what am I getting at? There's a significant amount of stenoses that can become painful, especially foraminal stenoses throughout the lumbar spine and cervical spine. Even in the lumbar spine, canal stenosis is typically not dangerous. It is painful, can cause claudication, but typically not weakness. In the cervical spine, thoracic spine, canal stenosis is dangerous, maybe not painful. So we have to separate those two things. We have to start separating those two things in neurosurgery. What is dangerous? What is painful? If a patient has a cervical myelopathy from severe stenosis and neurogenic claudication from lumbar stenosis, our priority is decompressing the cervical stenosis because the pain can be treated in other ways from the lumbar stenosis. So even in instances where there's a significant pathology at multiple levels or previous surgeries that are now failing, or previous surgeries that are causing adjacent segment disease. Even in these situations, if we don't find instability or dangerous stenosis causing myelopathy or weakness, we have an option for pain management. Let's go to the next slide. So what is pain? Let's go to the next slide. What is pain management? There are only 3 things in pain management that we use regularly. So if we're not operating on someone with these issues, we say they're stable, they don't have a critical dangerous stenosis. Let's try medicines, injections, and therapy. That's it. There is acupuncture, there is massage, there are all sorts of devices you can find on Amazon that make you feel better. You know, you can put orthotics in your shoes, I suppose, but in the clinical setting, medicines, injections, and therapy. And if somebody benefits from those on a temporary basis for a problem that is painful but not dangerous, we can continue those as long as they're safe to continue. If, on the other hand, they're only getting temporary relief but need permanent relief for permanent issue, stimulation is a good option. Let's go to the next slide. So this is how it works in the United States and how we found it works here in Kisumu. Someone has back pain, they go to the neurosurgeon. It's usually not the neurosurgeon who needs to help them first. It's typically a primary care physician that can manage this, or a pain management physician that can manage it, because when the problem is painful but not dangerous, there are many things that primary care physicians and pain management physicians can do to try to cover the pain. If they don't work, the patient can become surgical. Often we'll say the patient has an issue that looks surgical electively, but unless they fail conservative measures, they're not surgical. So actually going through conservative measures is a requirement to become a candidate for surgery. In the United States, we can't even get an MRI on many patients until they've had 6 weeks of physical therapy or some physical therapy and failed. So insurance companies will keep the patient from getting the MRI. In other words, you have to have some kind of conservative management before you can even proceed with an MRI to look for surgical pathology. All right, let's go to the next slide. So here, who do we see in clinic? 70 to 90%, I mean, depending who you talk to and how efficiently their clinic is triaged. In America and here, we've seen it the same way. The vast majority of patients are non-surgical off the bat. Why not? There's no surgical pathology. That's an easy one. MRI report is negative. Or they're surgical, but only if conservative measures fail. They haven't tried anything else. No medicines, no injections, no therapies. So not surgical yet, but the MRI shows a possible surgical lesion. Or they're surgical, but they're just a poor candidate. Maybe an outpatient procedure would be okay. Maybe an awake procedure without general anesthesia would be safe for them. But a general surgery with high blood loss, like a spine fusion, they're not a candidate for. So the vast majority of patients we see, even with surgical pathology on the MRI, can't have surgery. So those people are candidates for stimulation. That's who we're thinking about for stimulation. In the studies, as the years have gone on, spinal cord stimulation has been, when we try it, 50% effective initially. And now with new programming, new technologies, it's more on the order of 80 to 90%. And part of that is because we have a better understanding of who may benefit from stimulation. And so the results have been better because we are choosing our patients better. And what does that mean? Proceed with a permanent implant. When we stimulate the spinal cord to cover pain, we're putting in two, sometimes one, epidural electrode. It's usually in the mid-thoracic spine to cover lumbar and leg issues, or the high cervical spine, C2, to cover neck and arm issues. We do that percutaneously through a needle, awake. We thread the wires up into the epidural space, we test it, and then we send the patient home with external wires, and they can test this device at home for a week. If they like it, we implant it all with a battery under the skin like a pacemaker. The first procedure takes about 15 or 20 minutes, and they're awake. The second procedure, we typically do under general anesthesia, but it can be done awake. Takes about 30 minutes, and they go home the same day both times. So 2 outpatient procedures. We now know about 80 to 90% benefit from the trial and decide to do the implant. All right, let's go to the next. We can go to the next one. So what do we use this for mostly? You know, we looked at all those scans initially. Failed back syndrome is the #1 diagnosis. Somebody who has had conservative measures, failed, had surgery, and has not had enough pain relief to be functionally improved. So still seeking medical care for pain after a fusion. So failed back syndrome, but even patients that have not had surgery but have lumbar or cervical spondylosis issues are candidates for stimulation if you feel they're not candidates for a large surgery or general anesthesia. And then peripheral, actually, since this was first made, diabetic neuropathy is now in the approved column. I highlight the ones in this column that are off-label uses as ones that I've also done when we do finally get the insurance approval and we find good results. But these are more anecdotal. We're waiting on final results to have them be approved entirely by the FDA. Failed back syndrome, though, is the top diagnosis. Let's go to the next one. So when I talk to a patient in the clinic about whether we should try a stimulator or not, I may see multi-level foraminal stenosis in a 70-year-old female with diabetes and heart disease. So multi-level foraminal stenosis may require that you remove the facets at multiple levels, do a fusion, 6 to 12-week recovery period, several days in the hospital, large blood loss possibly, and a long period of general anesthesia. So we have that option. We have the option for surgery, and we have the option for stimulation because they have a painful but not dangerous stenosis. So when I do a fusion or decompression, those are the other 2 options. We change the anatomy of the spine. Decompression may cause instability later. A fusion may cause adjacent segment disease. Fusions on their own may cause certain complications that we have to deal with in the hospital, and it's less predictable. Like I say, the majority of our patients, maybe not the majority, depending what clinic you're in, but many of our patients would never meet the inclusion criteria for any of the studies that predict pain relief after fusion. And so it is very unpredictable if you're approaching the surgery for pain control alone. The stimulator, it preserves the native spine. The electrodes are placed in the interlaminar space through a needle. You don't have to do a laminectomy or laminotomy. It's reversible. If after 5 years they say it's not helping my pain, we can remove it without having to change the natural spine at all. And it's predictable because we can do a trial for a week with the electrodes in before we place the battery. And so given these two options for many patients, the stimulator is the better option. Rather than implanting rods and screws, we implant a wire and battery. Let's go to the next slide. Let's go next slide. So, when we get into the technical aspects of it, some surgeons will do their own trials. Many times it's an anesthesia pain medicine doctor that does the trial through a needle. The wire goes up to about T8 or in the cervical spine C2. The wire is coming out of the back and taped down here to a box. And the patient with the remote control can turn it off or on. They can put it in the left leg or right leg, and we can program it in ways that feel good for them. Or the surgeon can do it. We typically need certain x-rays to see where the trial electrodes were placed. And then we try to match those, that level in the permanent implantation to make sure that we get the same coverage between both. So we need to know, where was it placed in the trial? Where was it placed the day they pulled it? And what kind of programs were being used? There are 16 total electrodes placed in the epidural space in the mid-thoracic spine or high cervical spine. And a program typically requires 2 to 4 of the electrodes in any pattern. And so you can imagine there are thousands of different patterns you can use of programs. Let's go to the next slide. All right, next one. So again, we can decide whether we're going to do the trial or send the trial out to a pain management physician. But in general, my recommendation is that neurosurgery and orthopedic surgery, spine surgery, should be managing the surgical part of this whole process. And it's because we would have the capability, if needed, to do a laminectomy if there's scar tissue, for instance, preventing threading of the electrode. If we need to put a certain type of lead that's wider that requires a little laminotomy, if revisions need to be done, if the patient develops an epidural hematoma. And in the last 12 years that I've been doing this, I've had 3 epidural hematomas from this, but at the time of surgery or just post-op, we take them for laminectomies and they have recovered. If they're in an outpatient pain clinic, getting them transported to a place where then they have the laminectomies, may result in poor outcome. So I do think that the stimulator should be under the auspices of the neurosurgical or spine program. Let's go to the next one. All right, so the permanent implants can be any variety of electrodes. All these companies have different electrodes that we can use. Some go through the needle, and that's what we tend to use most. Some can be implanted through a laminectomy, and many surgeons are more comfortable with that actually, rather than doing an epidural stick and threading the needle up. Once we've implanted permanently, there's one incision where we bury the wires and one incision where we bury the battery. We typically ask the patient to tell us where they want the battery, what's going to be most comfortable for them. This requires x-ray to match the trial. You can go to the next. So in order to get a good outcome, if somebody has a trial with one of the 5 available companies, Boston Scientific, Medtronic, Nevro now is a new one, you should do the permanent with the same company. You want to make sure that the trial that they've had for a week matches the permanent. They feel the same in both. You should use the same type of lead for the permanent and the trial. And I always let the patient, like I say, choose the battery site, whatever's going to be most comfortable for them. Oh, also I should mention, there are 2 types of battery. One is rechargeable. So the patient sits on a pad every few days and charges the battery up. The battery lasts 10 years under those circumstances. It's guaranteed 9.5 years, but about 10 years. Or there's what's called a primary cell battery. It's a little larger, but the patient doesn't have to recharge it. It will just run 24/7 for several years. And then eventually we replace the battery in the battery pocket. Only the wires don't have to be replaced. You can go to the next one. These are all MRI compatible. So you can see here's that patient we showed in the beginning. There were bilateral fractures of the rods, continued spondylosis above, no instability, no significant stenosis. So we place a paddle lead here and we find, okay, it's It's improving their pain, but the patient was getting rib stimulation. Sometimes the stimulator, the pattern of it, the shape of it, can cause side effects. So they'll feel some pain relief in the back and legs, but they can get stimulation of the ribs, which is uncomfortable. And we have options for different leads in different locations to try to accommodate that pain and to remove the side effect. You can go to the next one, please. If there's fusion across the target level, let's say T8, and there is no area where I can place a needle, then this requires a surgeon to do a small laminotomy, identify the dura and thread the electrodes up. It doesn't prevent a person from having it. If it's done completely by pain management, then they would say you're not a candidate for stimulation because we can't enter the epidural space. But in the neurosurgery clinic, we can enter the epidural space through a small laminotomy. You can go to the next one. There are multiple companies that provide these. This one actually has already gone out of business, but the remainder have small little differences. All of them seem to work about the same. They're all MRI compatible. You can go to the next one. This is something that I do for my stimulator patients, but for all my patients as well. There's a certain infection prep that we do. Everybody gets a swab, a nasal swab done. We want to see if they have methicillin resistant staph. If they do, our preoperative antibiotics would be different. But I do place vancomycin powder in every wound, and it's been shown in the neurosurgical literature, especially for posterior cervical surgery, to significantly decrease infection rates, and we have found that to be true. Also, anytime you implant the implants deeper, the chance for infection is less. The stimulator, unfortunately, can only go one inch or 2 centimeters under the skin. All right, we can go to the next one. This is some of the reimbursements. I will talk a little bit about the cost. So for a neurosurgeon, this is it's a smaller reimbursement case. It doesn't reimburse as much as the other surgeries we do, but the management of the patient postoperatively is far less. We will see the patients in 10 days to check their wounds, but beyond that, the programming is all done by the companies. It's not something that we have to follow up on too much. And when the battery runs out several years later, they'll come back to get the battery changed. The problem here, and even at home in my home hospital, is that the price of the equipment right now is very high. So I looked at it, we just renegotiated with the companies at our hospital and got the price from $22,000 to $17,000 for the battery and wires. That's right now it's 2 million Kenyan shillings just for the equipment. The actual operation is very inexpensive, but the equipment is very expensive. And so the hospital, the margins for the hospital are very small. And I was asked by the hospital to maybe do fewer of these because the margins were small, or they were hoping they could be done in an outpatient clinic with pain management rather than utilizing neurosurgery time for it. Because neurosurgery time can be more lucrative for a hospital if it's spent doing fusions rather than stimulation. But we keep going with stimulation, and so this is just some of the financial difficulty that we have to deal with. That said, it is worthwhile. It's worth the fight. So many patients can be improved with this and without surgery. Go to the next one. So, stimulation, just like, yeah, Doctor.
We're going to see the questions on the end.
Okay, and this is the last one. I trained also in endovascular neurosurgery, and at that time, our radiologists were doing the coiling of the aneurysms. We hired a neurosurgeon at my residency program who did that, and what we discovered was instead of sending someone to see if they could be coiled, we were making decisions about whether coiling or clipping for that patient was better in our hands. What were the pitfalls either way? The other option is you send it to the radiologist who says, I don't think I want to coil this. Now you have to clip it. And it doesn't mean the clipping is better and safer. It means that they're not going to do the coiling, even though it may be better and safer for that patient. Same thing applies to radiosurgery. Neurosurgery should be doing it. Even though radiation oncologists can do it, neurosurgeons need to know, I will radiate this. I may operate on it post-op. I may want to operate now and do the radiation later. So these are things that have come under the auspices of neurosurgery over time, I think to great advantage to the patient. Same thing with stimulation. It did start in the pain management community, but it is starting to come over to the neurosurgical community, and so much more can be done for the patients because of that. That's it. If there's any questions, we can keep moving.
We have time for just one question and then we're gonna go out to lunch.
Just super brief, you mentioned the cost, and that's the conundrum in the United States, is that hospitals will make more money on bigger operations, and that's true. Here, I think the financial motivations are not the same. What's the price of a device, stimulator, and how does that compare to half a dozen screws and two more rods and pelvic fixation?
Right. So depending on the company you use, if you're say do a very common L4 to S1 decompression fixation fusion, you're looking at maybe $6,000 worth of equipment rather than $17,000 worth of equipment. But in this case, you have an outpatient procedure. You have no physical therapy afterwards. You have no hospital stay afterwards. The cost of a fusion postoperatively for 3 months is high. The global period is 90 days. Global period for this is 10 days. And so any even reprogramming sessions after 10 days are reimbursable. So the overall cost to the hospital system, everybody in the hospital have their own budget. And so they're only worried about, say, the OR budget and the equipment budget, but the overall cost of the hospital may be less. If you want to try to start to do this in a place where there are fewer resources, using the very basic electrode and very basic non-rechargeable battery, which would be far less cost, maybe on the order of 10,000 rather than 17,000, would start to become closer to what a fusion would cost as far as equipment goes, but the post-operative care would be far less. And the outcomes are nearly equivalent. There are some very cool, gimmicky technological things that we can do with the newer rechargeable batteries, but the pain control is very similar with a primary cell and a basic electrode. You don't always need 2 electrodes or paddle lead and a rechargeable battery. So there are ways to make it work.
Thank you, Dr. Karras. Please go on lunch. On your way out, you're going to get a voucher at the desk over here, and then just head over to the restaurant. Get your lunch. Okay, do me a favor. We have to be back in here.
been friends ever since then. So we worked together some few years back. It's amazing how fast that time has gone by. But we worked together in Ohio at the same hospital we were both previously at. So it's a pleasure to have you here, Dr. Nobel. Take it from here. Okay.
Don't want to. I'll stand on the side. Well, is everybody going to be awake? Because I know I've got a wonderful habit.
It's like this whole game.
Falling asleep after lunch and trying to that my presentations go very quickly. So I'd like to keep this kind of entertaining, but very realistic at the same time. So my title slide is an interesting slide just from the standpoint that I am mid-career. So I am the dad that the little kids go up to and say, why can't you figure out how to use this iPad? And I look at the stupid thing and I can't figure out how to use it. And there are other little devices and toys, like I can't play video games because there are too many buttons to push. I remember the day with the joystick. I remember Atari. And I remember tube televisions, which nobody in this room probably can appreciate with few exceptions. And that circles into my talk of technology in the operating room. Because when do you become a dinosaur? Do you lose the ability to appreciate technology? So we can go to my next slide. So, what is reality thoughts that I want you to go home with as we forward? Because the whole idea of reality is sort of what dictates where I think technology is going, especially for neurosurgery. So the reality of neurosurgery is constantly changing as new care modalities, plans and pathways are being developed. So it leads to the idea that our profession is going to continuously evolve. And it has to evolve. Because if we stay stagnant, we're not going to be able to come up with new treatment modalities. And likewise, you'll have the old guy like me with his children not able to figure out how to use an iPhone. I mean, I only text, email, and know how it makes phone calls. That's about it. I can't figure out the stupid thing. But that's going to bring up a very salient point that I'm going to come back to at the end of this talk. So let's go to the next slide. So virtual surgery. I separated it into two separate things. One, that it can be great for the patients because I can offer a better explanation of what the surgery is they're about to embark upon, which I feel is a very, very important part of recovery and of communication. You can review your complications much more easily, and you can improve the patient experience. So what is meant by that? There are places which have the ability to walk people through their surgeries, can show various types of images, show various stages of what to expect. But then for the trainees, and forgive me, you sort of lost part of the back, it can improve the neurosurgical education. Virtual surgery can come at a low cost. It can be safe and repeatable. So when you can simulate surgeries, which people are starting to do, you can sit in your room, you can put your goggles on, and you can look around and say, wow, I can do this surgery. Keep that in mind. That's going to be another point we're going to get back to when I get back to the old dinosaur who can't figure out how to use a cell phone. But for trainees in your situation, Kisumu, the idea of being able to discuss a case virtually is going to become very important. As I was listening, And everybody thought I was asleep back there, which is wrong. The idea of being able to go through cases virtually and to contact us using all these technologies to say, hey, I don't know what to do here. You know, let's phone a friend, is going to become a very powerful tool that we can use to continue this program to enhance the education of individuals here. But what is the price going to be? What is required? And the number one thing that I'll complain about from being here is what was referred to earlier, is we have no Wi-Fi. Yeah, there's Wi-Fi in the hospital. I really don't know what it is, but how are we going to communicate? So we have to up the ante, and that's one small step, a simple step, because the moment you have that, it's going to bring some of the virtual images to life. It's going to be able to allow us to communicate even across the big body of water that we fly over to come here. So can we go to the next slide? So virtual surgery, like I said, it's great for patients, better outcomes, better education, effectiveness, and simulation possibilities. So that's just one whole aspect where you can get a computer simulation, walk through the surgery, understand the anatomy, and you can modify it for each individual case you're about to do. Go to the next slide. However, anybody who's my year and my age who remembers audio, because everybody hates my music, there's something, is it live or is it Memorex? Does anybody who's younger know what I'm talking about? Oh my God. Do you guys know what 8-track tapes are? Do you know what cassette tapes are? Okay. What? Does anybody know what DVDs are? Yes. CDs. You remember we used to have that format. So there was this thing with Aretha Franklin who was recorded with this guy sitting in the chair. You can't really see the image. And by the way, my son had to do the slides because mine were really boring. Where the guy's just sitting back there listening to the music as it blows him away. But the question is it live or is it Memorex? When we start talking about virtual surgery, we have to keep in mind this quote. Real versus artificial goes way beyond Christmas trees. Now in the United States, we have a little thing with Christmas trees. Do we get a real one? Do we get a fake one? So when I consider one next to the other, I always think of the Memorex tape. In the 1970s and 80s, the Memorex Corporation produced these audio cassettes. They were the precursor of compact discs, which, God, I remember that transition. In their TV commercials, was Ella Fitzgerald, I forgot. The sound that she produced was powerful enough to shatter glass. That was that virtual reality. It seemed so real. Then they play the recording and the wine glass still would shatter. Begging question, is it live or is it Memorex? So when we start teaching you, what is better, virtual reality or the real situation? So let's go to the next slide. So it's sort of like asking Siri, hey Siri, what's the weather today? Hey Siri, am I going to be able to get a date today? Hey Siri, can so-and-so date my daughter today? That's our virtual assistant. Hey Siri, I'm stuck in surgery. What do I do here? Because I don't know what to do. Because I've done all the virtual reality that I can, and I've been with all the technology, and I forgot what it means to smell smoke in the operating room when I'm using cautery. So, can we go to the next slide? So neurosurgery taught through virtual reality, it should be an aid. Augmented reality versus virtual reality. We can augment our realities and maintain what's real versus going to a virtual environment where we replace everything that's real. So you need to obtain the actual and real experience of what surgery is. Go to the next slide. So we want to combine the two technologies. Now I can show you all different technologies, and I'll show you a couple of cool things and where I'm headed in my hospital. But we have to have a fundamental skill set, and we have to use that skill set and then use the virtual component to augment it. So virtual reality lets the neurosurgery patient look into our brains and then allow us to create more precision surgery. Let's go to the next. So when I start talking about technology in the OR, this is some old technology, which is very simple, but I really felt that it was quite spectacular because I had done my research, believe it or not, I did research before I became a neurosurgeon into something similar to 5-ALA for tumor resections. And it's something simple, it's something that's technological, and it's something that can be easily done even out here once you get your operating microscope. And if you look at my intraoperative view, I initially give the patients the 5-ALA pre-op 24 hours, let them sit around, they're photosensitive, and I bring them into the operating room, and you can see the intraoperative view versus the 5-ALA view through my microscope, and you can see that red enhancement. And these are real pictures, these are real case. This is really what I did. And you can see the pre and post-surgical views. That's a little bit of technology that's kind of cool, kind of old, but you need a new microscope, you need the lights, you need the ability to do it at your hospital. Cheap and easy technology, and it allowed me to improve my tumor resection. This guy's now, I think, 18 months. They said it was a glioma, but we can always debate that because that's up to pathologic interpretation. But it's relatively kind of eloquent resection, but straightforward. Simple technology, but very powerful. Let's go to the next case. But we start going into augmented reality. So 5-ALA's hands-on, simple, look at it. If you know what to do, it's easy to use. But now we start getting into augmented reality where we take our current skills and we augment them. We make them better. We make us a stronger human, Superman neurosurgeons. We can do it in spine with virtual goggles, virtual displays, heads-up displays. We can do it in the brain with stealth, simulation where we have virtual images. Ability to image is going to be very, very important because if you don't have the conceptual ability to look at a slide or an MRI and then translate that to real life, it's going to be a very difficult profession for you to go into. We use cortical stimulation. We use continuous monitoring. These are technologies which are more and more expected in the US, but are going to be difficult right now to obtain here. But these are steps forward with what you need to improve surgical ability. What I think can be done, though, is the virtual education. And that's what's been discussed already. So simulation-based training, and the idea is to reduce errors and improve outcomes. Go to the next slide. So image guide. These are two popular items. We can discuss offline whether robotic surgery is worth it or not. It's a really cool toy. I happen to have it in the operating room. We see more frequently the O-arm, which is the device down below, which allows for not quite real-time imaging, but rapid ability to obtain images. And they all seem to improve the outcomes. Next slide. So the Mazor, which is one of the toys that I get to show off a little bit, I happen to have one of these robotic devices. It allows for a little bit more precise placement of my screws, but honestly, it allows me to have my PA put screws in on the contralateral side while I'm doing my side, the old style technique. And this allows me to enhance the ability of my PA. And that is actually me. God, I love it. 4 years COVID. Let's move forward. Now, the next technology that I'm starting to look at and we introduced to the hospital is going to be true augmented reality, where we're using heads-up display and virtual reality goggles. But in order to do that, you have to have a 3D C-arm of some with this type of image acquisition capability in order to download the images into the computer system to use, again, an augmented platform to do virtual reality surgery. And if we go to the next slide. For people who are interested in this type of technology, it did get its recent FDA clearances for both cervical and thoracic spine. It was originally used for lumbar spine, and it's being sold in various institutions. They've done 3,000 cases with these goggles. You put them right on your head and you have an image which you can appreciate, which will allow you to guide yourself through surgeries. Let's go to the next slide. This is an example of some of the images that you can see. This is the augmented system, and we have a little better images if we go to the next one. And here they started using some artificial intelligence to actually take the images that are acquired on the 3D C-arm, modify them so in such a way that we can have better appreciation of where we're placing our screws. And this is what you see directly through the goggles. Next slide. But that brings us back to, so where does this leave us? We got all these cool toys. It's really awesome, isn't it? So with great powers come great responsibilities. Who hasn't heard of that phrase before? Does anybody know that phrase? Okay, that little Spider-Man dude. I don't know if that's the real guy who played Spider-Man, but I thought it was a picture. So you have to consider where you want to go with technology, because technology can't serve as a substitute for good education, good experience, and being in the OR. And let's go to the next slide. So everything kind of works in circles. And where does that bring me to? Yes, I'm the dinosaur who can't work his iPhone and doesn't really care, as long as it allows me to speak to whomever it is I want to communicate with. Yesterday's case where we did together, I had no technology. I didn't even have thrombolytics. I didn't have a drill that worked the way I'm used to having it work. I had staff I'd never worked with before. I had nothing cool, no monitoring, no nothing. But we got the tumor out, we had a good case. Why? Because when you go back to your basics and understand those basics and smell and breathe everything that you do in these hospitals, you become a better doctor. These technologies, though they may be cool and they cost a lot of money, may not offer anything in the end. Humans cannot be replaced. There's nothing better than, as Dr. Patel said, this little device right here. You put your finger on the sinus, I can only imagine how he told the nurse, take your finger off that, the patient will die. I just know. But he's 100% right. And when we train and we discuss and we do these case conferences, these are very, very powerful. We may want all these toys, you may want to bring these toys in, but where are you going to put them in the hospital? How are you going to take care of them? Who's going to look after them? Who's going to maintain them? And after a while, like my robot, it'll sit in the corner and it'll look over there all sad and everything, because I really don't need it. I like having it, and I hope my CEO's not watching, but we have to go to the next step. You know, I'm getting augmented reality goggles, and yeah, it'll help me a lot. But in the end, knowing where to put the pedicle screw, knowing the anatomy, knowing how to get out of trouble, knowing how to fix things is more important. So, circling all the way back, a mid-perspective view, everything in medicine works in circles. What you think is silly in the beginning when you're a young buck, you'll actually realize when you get older, works really well. It's like my daughter, you know, I'm the dumbest person in the world right now. I'll never forget when she walked up the stairs and I told her to do her homework. She turned around and looked at me, 8 years old, and said, "You ruined my life." 8 years old. Fast forward 12 years later, Dad, should I date this guy? What should I do? Where should I live? You're a smart guy now. So I didn't get any smarter. I just got older, wiser, but it was experience that made me better. So that's the end of my conversation. My discussion is more philosophical than showing you toys and all these cool things. You can look them up. You can get your new iPhone. So I'll end it here. Question, sir?
Any questions for Dr. Karras?
Garrett.
Oh.
Man.
I'm a virtual person. You'll see me for Verizon.
Compliment.
Okay.
Any questions for Dr.
What
LaBelle?
was that? This is the called the virtual reality 3D goggle.
Augmetics is one of the systems. There are various other companies that are coming up with platforms, but they hold a lot of the patents with some of the tracking devices. I know that Dr. Wars tried it. We've used it at OSU. And
How do you
I'm,
guys like it? Is it useful?
Well, when I tried the goggles, the issue was that it, you know, like anything else, when you try new technology, it slows you down. So for me, okay, you know, when I look at new technology, several things I look at. One is cost. Is it going to be more efficient? And is it going to be safer? These are the three things that determine whether or not I'm going to use a new technology. Is it going to increase my efficiency? Is it going to be safer? Is it cost effective? If those three boxes aren't checked, at least one of them, then for me, it's not worth it. Right now, we do surgeries very safely. Say, for example, spine surgery with using what we currently use, the OR. I'm efficient with it, safe, and it's something we already have, so it's no additional cost. So that was it for me with the goggles, and also this that everyone else. I want everyone else to see what I'm seeing in real time in the room in case we need to adjust something. So, and the other thing is, the more people it requires in the room. So I found that I had a rep. I still needed the OR, at least when I tested it. So I'm adding more technology in the room that makes things a little bit more chaotic. I still have the OR, and then I have now the goggles. Okay, now I need another rep who's for the goggles. I need a rep, you know. So it's too many players in it without increasing efficiency, without decreasing costs, and without increasing safety.
But that's still in the trial case.
No, I mean, there are places out there that have them, and it might work for some people better than others. It's just that with our system, we have dealing with a significant amount of spine and just the way we do things at being a level 1 trauma center. Just, I think the efficiency that we have right now with the tools we have is hard to beat until something else comes. I tried the robot too. For me, it wasn't as helpful. It actually slowed me down without increasing my efficiency, but adding cost. All right, so we're going to move on to the next talk. Thank you, Dr. LaBelle. My excuse is that Dr. Tim Ogutu, I'm starting to forget names now. Dr. Tim Ogutu said that once you get old, like 40 and 50, you heard his talk. So I'm instead of an older 40-year-old patient. So that's me now.
It's all right. It's all right.
So he called me. He called us old, and Dr. Lunya says that means I'm a fossil. But without further ado, Dr. Ben Okanga, we're going to go ahead with your search.
Thanks. Good afternoon. I'm Dr. Ben Okanga from Boston. He is my colleague and the 4th-year resident, Dr. James Kilo. Our talk is more basic about TB spine. TB is maybe one of the oldest diseases known to medicine. As we know, it affects all the organ systems. This part of the world, it's endemic. Africa, I think in Asia, it's endemic. And we find that because it affects all organ systems, it includes bones and joints, and fortunately, about half the time when you have bone and joint involvement, then you have spine involvement. And as much as we know about TB, and as much as there are so many new proven medical therapies for TB, find that there's a lot of deformity, neurological deficit until today. So we thought it would be important to revisit this topic. My colleague will take us through the talk, and if there are any questions or comments or questions at the end,
TB spine is an issue. Probably described in literature, Indian pathologists, well as in Egyptian money. Was probably brought to the limelight by Dr. Port, who was an orthopedic surgeon in 1997, describing it as a sort of paralysis that was associated with deformity of the spine. And what we chose to do is just to look at our surgical experience at our course general, see how that would trigger. So what we did a retrospective study over the last year. And what we found, we had done 9 cases. In terms of age, the youngest patient was 18 years, oldest patient being 71, the median age of 33, mean age of 40. Most of these patients were male. In the chart is myself. So, but basically, what we're trying to describe, we saw more thoracic cases, and for the thoracic cases, we did anterolateral plus posterior approaches for these cases. So in terms of pathology, we saw more thoracic. In terms of our approach to surgery, we did anterolateral plus posterior approaches. And therefore, in terms of active disease over acute disease, for the patients who operated with active disease, major indication for surgery was neurologic deficit. This was the same case in acute disease. However, with the acute disease, we had more cases of instability. Therefore, this is just an overview of what we use to grade our patients pre-op and post-op. We're able to use the modified Tully classification. Tully described an initial classification that had 4 stages. This was modified by Jane. Therefore, if I can just do a summary of this data, preoperatively, we had improvement in surgical management of the disease post-op in all the patients that we operated. Therefore, maybe Dr. Okanga can help me with some of the cases we've done. So this was a 38-year-old male diagnosed MRI, where MRI we able to see L3, L4, which would show tubercular spondylolisthesis. This patient had a modified Tully grade of stage 2. He had a bit of spasticity, but the patient could walk. Mainly the weakness was on the right side. We were able to do an anterior debridement, an autologous graft from the iliac spine was taken, and we did posterior screws as well. And these are the post-operative images. The patient was initially walking on crutches, but he was able to walk without them onto them. The next case was a 28-year-old male with T9, T10. And this patient is probably the most interesting patient in the series. He had a modified Tully stage of grade 5. He had classic paraplegia pre-op, and we did an anterior pterolateral approach plus a posterior approach, and we were able to get significant improvement to our Tully grade 2. These are the post-operative image. This is the patient. He still had some weakness on the limbs, but he was able to put this time. Next case. This is a case of T11, T12. This spine patient had thoracic myelopathy modified to stage 3. You can see on the MRI image severe cord compression there. Lead and anterior debridement plus posterior pedicle screw. And these are the post-op images. Therefore, if you can go into this discussion on TB, it's fine, especially in terms of data within the Kenyan region. Our prevalence was noted to be about 558,000, 558 over per 100,000. This was a really high disease burden, and this was seen mainly young adults 25 to 34 years of age. And actually, Kenya is listed amongst one of the 30 high burden TB diseases. That's why we chose this today. Therefore, in terms of pathophysiology, causative agent is the Mycobacterium tuberculosis, slow growing, fastigious aerobic bacilli. Pathologically, it causes cacheating necrosis associated with germ Langerhans cells. And therefore, it can spread via different ways, mostly hematogenous spread via paradiscal vessels. And as you can see from the image, anatomically, you can see how the disc is paired with early display to be bone blast. However, you can also have central involvement to the vertebral body, posterior elements, as well as an osseous involvement with cold abscess formation. Therefore, what this does is causing progressive osteolysis and osteonecrosis, eventually leading to collapse of the vertebral body, ability to be a deformity, and spinal cord compression causing neurologic deficit. In terms of distribution, even in our study, we will see most of these patients had thoracic TB. Post paraplegia, early onset disease, like you saw in our study, we did fewer of these cases. Mostly we had neurologic deficit and inactive disease, what we tend to see is invasion of the cord. While in later disease of hip release, mostly instability that comes to play. Therefore, you can have an instability score. This is just academic. What I want to maybe highlight here is spinal risk signs. And on the spinal risk signs, will give you a score of 3, and a score of 3 will give you an unstable spine. Therefore, maybe if we can look at the mechanics of the spine just a little bit, maybe what the few things I would like to get from this is that Euler was a great mathematician in the 18th century, and he did a lot of work in applied mathematics. And what you can see from this equation, this is the equation of critical load of buckling or buckling load, and it's an equation that is applicable for slender bars. And what we were able to see here is that the E in the equation there is a modulus of elasticity. This is the strength of whichever one or device you have. And the denominator there is length. And basically what we see is that the length of this limb bar, the longer it is, the lower its buckling load is. Therefore, when you deal with kyphotic spines, you generally increase the length of the spine and therefore lowering its buckling load. So basically that's what we've demonstrated. And this is just a few use of the fusion equipment that we use in spine fusion compared to cortical bone in terms of its modulus of elasticity. Therefore, these patients tend to present with pain. This pain is classic, it's rest pain. And usually this is because when the patient is resting is when you get relaxation of the posterior muscles and you get engulfment of this brain. And this is why this patient presents with classic nocturnal classic rest pain. Therefore, deformity, retropharyngeal masses, neck masses, neurologic deficits are some of the things that your patients will present with. This is just constitutional symptoms that show active disease. This is a Tully classification that we talked about before. Tully described the classification of four grades. However, this was modified by Jane to include grade five. Grade five here with the involvement of bowel and bladder function. And therefore, evaluation for these patients are able to do basically full blood works and basically do inflammatory markers to try and get whether it's active disease or not. To test is still an important test to do in this region. Therefore, imaging in terms of radiology, you want to do radiographs of the chest and spine, CT of the spine, MR. If you can do myelography or DEXA scan, that would be better. This is just a classic Wagner sign for involvement of thoracic spine. This is an image of a myelogram. And therefore, when you talk about surgical operation approach, we're basically able to do anterolateral approaches for most of our patients, especially in the thoracic spine. Therefore, when you're performing surgery for healed TB, basically what you're going to realize is that anterior approaches rarely suffice because you have to correct the kyphosis as well. And therefore, combined approaches are what will probably give you the best results. The newer techniques now involved are the transpedicular procedures with pedicle obstruction osteotomies, as well as wedge resections, as you can see from the images put up. Probably the future of surgical management of TB spine is with minimally invasive spine techniques. And these techniques are able to give you smaller incision, less blood loss, less post-operative pain, shorter post-op stay, as well as early return to work. And some of these minimally invasive spine techniques would involve video-assisted thoracoscopy surgeries, dorsal lateral metabolic fusion, as well as the oblique and extreme lateral. And endoscopies have gained huge traction in spine surgery, intraoperative monitoring as well, are adjuncts to the surgery. Therefore, when it comes to the principles of surgical management, TB, anti-TB drugs as a medical therapy are still the first-line therapy. However, surgical indications would be neurologic deficits, spine deformity, instability, oppression due to abscess, as well as clinical deterioration despite TB therapy. Therefore, surgically, what you want to do is get optimum debridement. There is probably change from radical debridement to optimum debridement, and this is to decompress the lesion as well as restoring spine stability. What you want is adequate bone contact, whether you're using allograft or whether you do a mesh cage. And with a mesh cage, you need to do bone graft so that you can get this adequate bone contact. Immediate stabilization by instrumentation is what you want to achieve as well. And the surgical approach basically tailored to the patient. Anti-TB treatment cannot be overemphasized. Therefore, in conclusion, like Dr. Okanga mentioned, TB spine is endemic in our region. Maybe something I haven't mentioned is that its association with HIV. So you get a lot of TB and HIV co-infections. Surgical management has been shown to be effective to be able to alleviate the patient's symptoms, from the case series. And with various approaches, we can actually get better results for this patient. However, this would be highly dependent on the institutional resources as well as the surgeon's ability. And what we found is that a combined anterolateral plus posterior approach offered better results than posterior only. Therefore, TB spine is an important disease in our region and it will continue to be so. So I think those are a few of my references. And then the talk.
Are there any questions?
Yeah. I have a question for my own education. Let me say, TB is really rare in Germany. I mean, I think even in Switzerland, I think maybe it's 2 or 3 times in 10 years or 20 years. And I'm not familiar with it. And what are the safety measures? Because that's where the problem usually occurs. When there's TB suspected, everybody goes crazy, and nobody really knows what needs to be done. Safety measures to prevent transmission to healthy patients or to the doctor themselves. What is the real? How do you need to treat it? How do you need to? What kind of safety measures do you need to have when let's say you're doing the surgery on it? Does the case have to be the first case of the day, the last case? How do you go about that?
Thanks. Whenever we do it, it's probably the second or third case of the day. TB is endemic here in Africa, and all of us get vaccinated at 6 weeks on their boosters. Because of all the recurrent exposure, we assume that there's just endemic immunity to TB. So in hope, I don't think so that we have any hoods or special masks against it. And even the infection rates are quite low.
And in the wards, because in Germany they get isolated. It's a big. They get isolated. It's kind of a big thing.
They're not isolated.
Not isolated. Okay.
Thank you so much. For our next talk, I would like, because some of the faculty have to catch a flight, Dr. Chinsama is going to be leaving here pretty soon. I'd like all the faculty real quick to get up to the front. We're going to take a quick faculty picture, and then we're going to keep going with the program. So real quick, let's just get all the faculty up front for a quick picture.
Very good presentation. Okay.
No, inakuja.
Here it's pretty, we can make sure that we can see.
Can you see everyone?
Yep.
Quickly, I'm holding my breath.
Sucking it in, not good.
We say ugali or chapati.
All right, thank you.
Sushi.
I think it's better. Oil.
I do. It's a great talk.
I know some people, some of the faculty have to leave. I'd just like to say thank you so much to the faculty for making this possible. Without the faculty, obviously you can't put something like this together. So for your commitment and for showing up, I really appreciate all the faculty being here, and safe travels for those who have to leave early. Next, we'll have Dr. Khalid. Well, it looks like we're having some issues with pulling up the next slide, so we're going to move on to the next talk. Actually, what we're going to have next is a panel. So we're going to have what we have learned from the let's see here. So we'll move on to the Kisumu Neuroscience Initiative, developing a global neurosurgery endeavor. And we're going to combine that with the other panel discussion, healthcare in Kenya, where we were, where we are, and where we're headed. So I'd like to ask for Dr. Galler, please come up, Dr. Lutha, Dr. Unya, Maybe we get Dr. Shitama, before you leave, maybe you can join us for this panel as well. Yeah. And I'm also going to have the CEO of Jaramogi Oginga Odinga Teaching and Referral Hospital join us as well. So I'll be back shortly, but go ahead and get it started.
All right. Get some of our faculty to come have a seat. Chris? Okay. We have you figure down. So I was asked to sort of moderate this this panel. I had a formal talk that I was thinking about giving, talking about my experiences in terms of doing global neurosurgery endeavors, which I was doing for many years. And the model that I had sort of based it on was something I had learned from the team at Cornell, which has got a very durable program that they've had in Tanzania for at least 15 years or so. And some of the ideas that I've stated today are not original. These are things that I've learned from my friends, and I think that they do translate well here. So one of the things I would like to talk about is some of the things that I learned from them and ask your opinions about how we could implement them here. One of them we discussed already, which is the idea of continuity with faculty and the idea of virtual conferencing. So I don't think we need to discuss that further in this forum, but some of the other things that are part of durable endeavors of this sort include data gathering, publications. One of the charts that Tim had put up was a chart that I had put together with some data that was collected from previous groups, including Beth Wells, as well as our groups and previous. In terms of our faculty here, I want to get some comments in terms of when we're here, is that data being gathered? Is it something valuable to the institution? Having that data to support the importance of the endeavor. Do we agree or disagree, or are we ambivalent that that is something that's a part of what the program should have?
Before we get started, what I'd like you to do is just to introduce all the faculty. Just introduce yourselves, and then because some people are joining us early and may not have seen your previous talk, so just introduce yourself, and then we'll go from there.
Yes, I'm Leo Buta, neurosurgeon based in Kisumu.
Dr. Sylvia Shitsama, a neurosurgeon and lecturer at Jomo Kenyatta University of Agriculture and Technology, and honorary lecturer, consultant neurosurgeon at Thika Level 5 in Kiambu County.
Timothy Obutu, neurosurgeon based in the City of Germany. Chris Garris, neurosurgeon based in Columbus, Ohio, with Capital Award.
David Rojo, surgeon based in Nairobi, and board member of the Jaramogi Teaching and Referral Hospital.
Good afternoon. My name is George Rai. I am the CEO for Jaramogi Oginga Odinga Teaching and Referral Hospital. Feel welcome.
Thank you. Pleasure to see you here. Thank you for joining us today.
Thank you, Dr. I was about to make a comment on data and then was coming to account. For the Kisumu Neurosurgery Symposium, since we started, actually we are keeping a running inventory of all the procedures we do. We are keeping records of our outcomes, and I think it is the first time such data is being collected in the region in terms of neurosurgical work and neurosurgical outcomes. And then it's already had an impact, because I remember between a camp we had in July last year, where we had a very high rate of surgical site infections post-operatively. We actually sat down and looked at that data and said, okay, what can we modify? And by the time we're having subsequent Dr. Obutu implemented some simple procedures as far as our skin preparation was concerned, as far as our tissue handling was concerned, as far as post-operative care principles were concerned, and our surgical site infections plummeted to virtually none from a point when we were doing multiple reuse and washouts from previous. So the data is being gathered, and it's already at an impact, and I hope
Excellent. In terms of you being now a full-time person that's here, I certainly think that would impact you the most, because if a camp arrives and provides care, you may end up being responsible for what's left behind. So I think we hope that these outcomes are improving. In terms of building the program, if I can ask Dr. Lunia to talk more to some of what the training program might look like as it relates to the camps, and how the visiting faculty might get involved in the teaching process.
Thank you for that. What is useful? I think this is in terms of value add. The company doing camps and just leaving it like that doesn't. You have these peaks and troughs in terms of everybody else benefiting. There is a break in the chain. We have leaked here, and as far as they're concerned, we are actually wanting to build up the people who are trainees and so on, who are more able to see how things work out. What we see is that if we plan it with the faculty coming through, the value addition, the special characteristics that they have, to be able to continue follow up, especially with the education aspect of things. It is easy enough just to read the book. And if you see how procedures are done and the thinking behind how some of these procedures are done, it makes no sense. So as we have seen in terms of the figures we're looking at, we're not looking at what you get 10 or 12 people per year. It's just enough, only 2 per year to be our capacity. And I think with a slow build in a layered approach, it's akin to if you want to paint a car. You don't put all the layers of book. Put in one layer, bake it, then you rub it down, and then you make sure it's finished up before it's on the next one. That's what we want to do. But when it's our program,
A little bit more. It sounds like infrastructure is building, processes are building, the amount of neurosurgeons are building. Are there any particular issues in neurosurgery that are delaying the advancement of neurosurgery that's not happening with other specialties? In other words, medicine is building, healthcare is advancing in Kenya. Is neurosurgery going with the flow? Are they advanced, or are they behind what's happening in the rest of Kenya? Do you feel that adding more neurosurgeons is the answer, or do you need now to catch up with all the typical ancillary services and medical services that would go along with those? I'd like your opinion, and maybe Jordan's. Yeah, forget it.
Say that what I'll do is.
So neurosurgery is catching up in terms of training and offering the service. But the one thing we've not been able to do is to look at our outcomes, like as a country, to say, where are we doing, where are we coming from? So before, we didn't have a lot of electronic medical records, but most counties are picking up with this. The biggest challenge is the administrative part, that you need a support system or someone who's in charge of that record, ensuring those records are inputted in the system, because maybe whatever is being captured is not necessarily everything that you need. Now, there are certain apps that can be used and are supported by other countries that are readily available to us, like I know RedCap. Even the Tanzanian team have a record database that they can allow you to access your information, and they can share it with you either monthly or every 2 months. And it's from that data you're able to say, okay, fine, maybe I need to make this modification, or maybe I need to add this. So it's a matter of us finding the collaboration, but really investing in the administrative arm. Because if we leave it to the neurosurgeons, then the management and collecting data will definitely be a challenge.
Yeah, I think the way I see it is basically the excitement by medical personnel, particularly doctors, to vie into the sphere of neurosurgery. A very common statement in Kenya today, when you ask young people what they want to become after exams, nearly all of them tell you they want to become neurosurgeons. I've never known why they all want to be neurosurgeons. Is that not true? When it comes to the time of being neurosurgeons, then you find very few people who want to be neurosurgeons. So within that period and the time of calling, something may have happened. At the time that I went in as an MO medical officer in 1977, there were absolutely no neurosurgeons in this part of the world. And in Nairobi, there was Dr. Dar and one more, and in the private sector, Dr. Robert. So for a population of about 30 million people. So the access was very little. Over the years, as people grew up, not very many people came forward to become neurosurgeons. And I've been asking myself, why? So there must be something in terms of sensitization of people to become neurosurgeons that we really need to address. Because over the years, the service need for neurosurgeon, the gap is so huge. Because within the last 15 years, there was the invention of motorbikes as a means of transport. So acute injury to the brain and the skull is actually an everyday thing in the whole space. Therefore, this calls for a different approach to neurosurgery. We have spread within Kisumu at least 10 hospitals, which can actually be centers where you do some form of life-saving neurosurgical operations. And therefore, the training must be different. Faculty at JOTRH with all these eminent neurosurgeons and people from Germany and Ohio, Atlanta, very good, and Nairobi and Mombasa. But we need now to change the paradigm and have everybody in some of the small hospitals become trainees for at least a certain element of life-saving operations in neurosurgery. As part and parcel of these camps that we have, so that we build the right threshold for life-saving. Because right now I sympathize with my brother Lee. He responds to everything in the town on a daily basis. Once the camp is gone, he responds to everything in the private sector, in the public sector, which creates a huge delay. People who would have benefited in the first 24 hours may deteriorate and become moribund and not be able to reverse their systems. So what have I said? I think we need to relook in terms of getting people who have the capacity to do neurosurgical life-saving operations, not just at JOTRH, but even in the smaller health facilities. Because I remember in my time in 77, 78, I used to do a lot of battles. I was in a place which was very violent. And a lot of people came in with epidural hematomas, subdural hematomas. And of course, at that time, you had to up-edge your clinical skills in narrowing down where the pathology is, and at best, do a carotid angiogram. The imaging technology hadn't developed in 77. But we saved lives. So I think even now, to extend that and get imaging, and imaging now has moved much, much further under a program called the Managed Equipment Services, which makes it easy to narrow down the diagnosis. So I think we need to rethink on making a wider space, getting more people interested, getting a wider space. And the good thing is that technology at this time is accessible. You can talk to students right now. There are people who are within this conference and are not in the country. So we can have classes from outside into the country, procedures from outside into the country, and bring the threshold of knowledge to an acceptable level.
To touch on your point, our team rounded yesterday on arrival, and reviewing patients on the ward, we had seen 2 patients who had had subdural hematomas evacuated. And to our surprise, they were performed by the general surgeons in the hospital rather than the neurosurgeon, which apparently here is becoming more and more standard. In the United States, the neurosurgeons would lose their minds at the idea of a general surgeon doing such a thing. But I think here it's to be considered and supported because, again, Lee is one person. If there are half a dozen other general surgeons that can support him, one way of retaining your faculty is to keep them sane, and sleeping is important. So having trauma faculty that's capable of doing neurosurgical procedures is also, I think, a benefit and a bonus. I wonder if any of the other local faculty or international faculty has an opinion about that.
Yeah, I think that's perfectly in order. As part of the general surgical training, neurosurgery is included. So by virtue of the fact that when they finish their master's of medicine surgery, you should be able to take care of your surgical emergencies.
In the States, that used to be the case, and general surgeons no longer rotate on the neurosurgery service regularly. We've sort of isolated ourselves into almost into a situation where now we're having a difficult time covering trauma centers in our own country with the massive number of surgeons that we have. So
bring them in.
Yeah, exactly. Well, one of the part of the presentation that we discussed here is that the ultimate job security is either in Kenya or Tanzania, because 1 to 100,000 1 to 100,000 population is the neurosurgical ratio in the States or other countries, where here it's 1 to 1.5 million or 1 to 3 million. So it's definite job security. I think your practice will flourish, and if it doesn't, you're doing something terribly wrong. So I think that's an interesting thing. The other thing I find interesting is that the neurosurgical diaspora of Kisumu is amazing. To think that this little town has created so many neurosurgeons per capita that it is quite extraordinary. And the fact that they've returned to put back the knowledge into the community is something quite special. In regards to that, with the training, does Kenya itself have difficulty retaining its best and brightest that are trained, or they find themselves training and going elsewhere and not returning? And any thoughts, certainly from our CEO, regarding that idea, so that we train our folks and to keep them here?
I don't think there's a problem in retaining the trained neurosurgeons in Kenya. I would support the movement, a free movement of human resources across the world. I do not ascribe to locking people in spaces and claiming them to be yours. We should open the space for exchange of ideas, exchange of skills, exchange of research thinking, because the latter, when people stuck in Ohio throughout, it's like brains in the drain, not brain drain. It's brain gain when you move, because you see things you never saw, you develop certain skills you never thought about. So I think we should strive towards the model that is happening in Kisumu much more often, so that even our neurosurgeons in Kisumu who have been in this space can move to Germany, Atlanta, UK, to work together with those people and gain further knowledge and the way of doing things. Because I believe in moving towards a one world space. Technology is supporting, attitudes must change, And we should have people certified to work everywhere at all the times.
I would ask a quick question for our CEO. As far as Jaramogi goes, is there a particular budget that is, I'm all about the money. Is there a particular budget for neurosurgery at Jaramogi? Is there a budget for neurosurgery, and how, or is it just for the surgery department, but is there something specific for neurosurgery that is allocated towards neurosurgery, and how do we determine how that money is spent?
There is no particular budget related to neurosurgery, but we have budgets related to surgery and service delivery. But as we get to interact, we think now we should move towards certain aspects of the budget related to neurosurgery. You realize that one of the biggest challenges in this country is actually financing the services in the country. It's much easier in the US, in Germany, because of the social health insurance in Germany and the kind of types of insurance and financing in the US, and the national, they call it National Health Service in the UK. We have a very low insurance uptake, both private insurance and social health insurance. At a maximum is only about 15% of the population, because the overall income, household income also is low. There is unemployment, there is no generation of money to be able to buy the insurance. But we think as we move towards getting everybody insured, and that has been passed in Parliament, that is now compulsory that everybody should have an insurance. To enforce it is not easy, but with that, we will be able to identify resources, financial resources to support neurosurgery. But I think neurosurgery should be supported, and I will make sure that in our next budget, we create an item called neurosurgery. Thank you.
I think with that, on time, we may want to move on to our next talk. Thank you very much, panel and faculty. Thank you, Dr. O'Rourke, for allowing me to participate in this matter. And I think we're going to carry on with the next talk. Keep moving.
Thank you.
Thank you so much.
Thank you.
The other doesn't. But he has.
Thank you very much. We are going to discuss a topic which was traditionally not a neurosurgical topic. We're going to discuss the management of ischemic stroke and the endovascular management of ischemic stroke next. This is going to be our objectives or outline. Stroke is defined as an abrupt onset of neurological symptoms or neurological dysfunction resulting from cerebrovascular insult or disease or impairment. So if you have neurological fallout, weakness, aphasia, anything neurologically that is resulting from diseases of the blood vessels, we'll call that stroke. There's a term called TIA, which we are all familiar with, transient ischemic attack. The definition is neurological impairment resulting from vascular pathology and is not lasting more than 24 hours or is not going to have changes in the MRI. That's the new definition. Next. So why do we need to discuss this? It's a very important public health topic. It's a leading cause of disability in the world. It's also a leading cause of mortality. There are two main types, the ischemic and hemorrhagic. The ischemic type of stroke is the more common one. Unfortunately, is the one that we can help patients. 15% are hemorrhagic, which can be divided into subarachnoid hemorrhage and intracerebral hemorrhage. In the US, where they have numbers for everything, at least 70 billion is used annually in treating these patients. Next. So 1 in 6 people will have a stroke in their lifetime, and stroke is a leading cause of mortality. 80% of patients who have stroke live in low and middle-income countries. So is the population of the world. 80% is low and middle-income countries. Next. So we have to understand clearly that stroke is a major public health issue. It's a leading cause of long-term disability in adults. So we have 2 main categories, as we mentioned. There is ischemic stroke, which basically means a vessel is blocked, and hemorrhagic stroke, which means a vessel has ruptured and there is blood in the brain. So 85% of the cases are ischemic. We have to understand that ischemic stroke has better prognosis than hemorrhagic stroke if treated in time. Both the outcome of these 2 types of stroke is dependent on timely recognition and timely treatment. The risk factors are similar, which we're going to see next. They both share the risk factors. So modifiable, non-modifiable, med student level things. So we all know of this. So if you smoke 200 kilos, you're hyperlipidemic, father had a stroke, you are male, you're alcoholic, all these things will make your risks higher. And if you're fit and young and healthy and good blood pressure control and not diabetic, your risk is low. Straightforward. Next. So how do we recognize patients with stroke? Their cardinal features. So these patients will present with facial groups, facial palsies. They'll present with arm and leg weakness, slurred speech. The most important thing that we need to know is, when did these symptoms start? Yeah. It's a very important question. The other thing is, they present with many neurological diseases, confusion sometimes, hemi-neglect, you can name it. The list is too wide. But this is what people have developed to recognize stroke fast. Next. So what happens when a patient comes to you, symptoms of strokes? So you need to do the basic things, ATLS, LCLS. You need to do a quick neurological assessment. There is no need of doing healing charts and doing detailed dermatomal examination. And the most important thing that you need to know is, when was the last time this patient was okay, last known well. But the next thing you need to do is, you need to take these patients into the stroke pathway. Next. So this is a tool we use for grading patients. It's called the NIHSS score. It is a way of finding out how sick you are or how severe your stroke is. It's also very commonly available. It's in your mobile phones. There's an app for it. It's available everywhere. Next. So we grade patients into mild or minor or moderate or severe strokes. And the higher your number, the severer your stroke. Next. So at the end of this, we need to have a simple stroke pathway for anyone who's attending. And you don't even have to be a doctor. The moment you get a patient you suspect to have a stroke, you need to have an algorithm or a plan on how to go about it. So the first thing is, you see a patient who is suspected to have stroke, you did your NIHSS score, you check your blood pressure and everything, you've done what needs to be done, then you suspect the patient has stroke. What needs to happen next? So from that point is, you need to be in a place where at least there's a CT scan. That's helpful. So the first thing you need to do is, you need to take this patient to CT scan, and you're just looking for 2 things. So is it hemorrhagic or is it ischemic? It's a simple question. CT scan will give you that answer very fast. You can guess clinically whether it's ischemic or hemorrhagic, but it's not always 100%. So patients who are presenting with severe headache generally have hemorrhagic stroke. Patients with ischemic stroke, headache is not a cardinal feature. So when you take this patient to CT scan and you find out whether they have hemorrhagic stroke or ischemic stroke, you pick one. So if the patient has hemorrhagic stroke, that's a different pathway. Now we'll stick with patients who have ischemic stroke. The ischemic stroke, when you are in the CT scan, realize that the patient has ischemic stroke. Probably there is nothing on the CT scan, it looks normal. You start giving TPA. So every hospital who has a CT scan should also have what is called a stroke box, or the stroke bag with TPA in it, and simple things to do. So once you give the TPA, you don't move back to the casualty. You stay in CT scan, you do a CT angio, okay? What you're looking for at this point is if the patient has a large vessel occlusion, okay? Next. That's a simple pathway. So the imaging the goal is to find out what type of stroke you have, or whether the patient has stroke or stroke mimics. You also need to identify if the patient has a large vessel occlusion, and if he does, is this patient a candidate for mechanical thrombectomy, which is what we're going to discuss, and why neurosurgeons are involved in the care of these patients. Next. So the CT scan will give you either of these two images. So the first one, this one, is an ischemic stroke, but there is nothing on the CT scan. It looks normal. And this one is a hemorrhagic stroke. So the main goal why you're taking the patient to CT scan very fast is to identify where they fall. So if the patient is in this group, that's what we're interested in today, is an ischemic stroke, which is 85% of the cases. And these are the patients that we can help if we have the resources. Next. So once the patient has ischemic stroke and we identified that and given them TPA, we need to have in our mind that this patient has a stroke. And if you don't do anything, a large part of their brain is going to die because they have a large vessel cutoff. So we need to save the penumbra. The penumbra is the tissue at risk. There's a core tissue that's already dead by the time the patient is coming to you, but there is some part of brain that we can still salvage. For these patients, blood pressure, you don't have to bring it down as fast as possible. The brain is trying to compensate. So you see the patient has blood pressure of 180 over 120. You don't have to bring it down very fast, or you don't have to bring it down because the brain is getting its supplies slowly from collaterals. So you give them TPA and you plan them for thrombectomy because they have a large vessel cutoff. Next. So time is brain. If you don't do anything, that part of the brain that was at risk will eventually die. So our job is to save the penumbra. Next. So we've discussed TPA. Next. So this is time, and this is what happens to the brain as we wait, as we find out if there's somebody who can do the CT scan, or if there's the CT scan is open, or if the patient can afford. So the more time we lose, so the patient, when they come to you, they are probably in this stage. The red part is dead brain, okay? And as you wait and find out the logistics, the patient might move to this, which means the brain is completely dead. That part is never going to come back, and the patient is going to have a permanent deficit. Next. Just another scan showing what happens if you don't do anything over time. So this is why time is brain. As you wait to intervene or the patient gets help, the more tissue that was at risk, the more it dies. Next. So what does a CT scan show you? So a CT scan, probably what you're looking for is a large vessel cutoff. So the major vessels we're going to discuss, but the most common one, in almost 90% or 85% of the cases, is M1 occlusion, okay? And that supplies a third of your hemisphere. So if that is occluded, you're going to have profound deficits. But if these patients get help, they go back to work and they live a normal life. Next. So mechanical thrombectomy is the solution to this, and it's something that has been available for a while now, but it's just starting in this country. And there's only one center which is routinely doing this. I've worked there for 4 years, so this I got a feel of it. So what we do is you just basically pull out the clot that is including the vessel, and you can do that via aspiration or balloon angioplasty. Next. There are multiple studies that show that this is an effective treatment and is now considered as a level 1 evidence. There is level 1 evidence for the treatment of stroke using a mechanical thrombectomy. Next. So this is what vessels of the brain look like. Once you push the contrast, this is on the left side, you need to see this anterior circulation. Next. So these are the vessels. I wanted to ask questions, but I think because of time, we'll not be able to do that. So these are the circulation of the anterior circulation on a lateral view and an AP view. Next. And this is the posterior circulation. So if these large vessels are occluded, these patients are going to have severe deficits and their life is going to be changed forever. So our job is to revascularize them on time and get them a chance in life. Next. So this is the entire circulation. This is the anterior circulation, and this is the posterior circulation. So if any of these large vessels are occluded, the patient is going to have deficits. I have to keep saying that. Next. So this is a lady we had who had a vessel cutoff. You can see this. This is the M1 occlusion at this level, and then after thrombectomy, there is some perfusion, but not full. Next. So this was another case we had, an 85-year-old lady who presented with right side weakness and aphasia. She came to the hospital within 2 hours. It's a video. Okay, next. So no. Yeah. So this one first. So if you look at it, keep going. Yeah, that is the cutoff. So you push the contrast, you don't see the entire M1 circulation. And this is what you see after you do the thrombectomy. So the entire circulation is restored, and the patient, of course, did very well. Next. So these are little cartoons showing what actually is a mechanical thrombectomy. Okay. So you introduce a catheter from the groin and you go all the way to the ICA and you go to the vessel of interest. You push the catheter beyond the clot, and then you deliver something called stent retriever. And then this device will amalgamate with the clot. Give it a few minutes, and then you'll be able to pull out the clot together with the stent solitaire. So that will open the vessel. Next. This is next. Yeah, this is what you get after that. So the entire clot is with the stent retriever, and the vessel occlusion is over. Next. So this is what happens. It's a CT angio that's showing left M1 occlusion, and this is what happens after you do the mechanical thrombectomy. So this entire brain that wasn't getting perfused is now getting perfused. And if this is done on time, these patients do very, very well. Next. So for every minute, every 30-minute delay you have a 10% relative reduction in good outcome. So they say every 1 minute, 2 million neurons die. I don't know who counted it, but it's something that's out there. So every minute delay will lead to 2 million neurons dying. Next. So multiple studies have shown that the number needed to treat for mechanical thrombectomy is excellent. So Mr. Clean showed that this number of 7 patients you treat, you get 1. But extend 1, for every 3 patients you treat with mechanical thrombectomy, you get 1 excellent result. And that is very, very good. It's a fantastic outcome. If you only do TPA, you have to treat a whole village to get a good outcome. Yeah, next. So like any other procedure or any other issue, this disease has also its own problems. After you perfuse this, some of the patients develop malignant edema, and you have to do a mechanical thrombectomy. And as Dr. Patel said in the morning, you have to have temporal decompression. You have to ensure that bone nibble it all the way to the baseline to decompress the temporal lobe. Next. So where is this available in the country at the moment? There is only one center which is routinely doing this with a stroke service, but there are 11 cath labs in the country. Yeah, those 11 cath labs, 9 in Nairobi, 2 are in Mombasa. So the rest of the country, there is none. There's nowhere else with a cath lab. So next, so that the 9 cath labs in Nairobi, and out of those 9, all of them are doing cardiac work. They are very busy doing cardiology. There's only one which is doing neuroendovascular. So next, there are 2 cath labs in Mombasa, one private, one public. In Nairobi, there are at least 2 public cath labs in 2 public hospitals, but the rest are in private hospitals. Next. But that is changing slowly. So we did our first DSA at Kenyatta University Hospital late last year, and that was the first DSA done in that hospital at that point, and we did an aneurysm. We did one last week in Mombasa, also the first time it was done a DSA in Mombasa together with Dr. Okanga, and this is going to change. So slowly, this has to become mainstream. Dr. Patel was telling me that endovascular is no longer use the word sexy, because because in the States now, even the small community hospitals are doing this, so it's no longer big. But in Kenya, it's something new, something that is starting. There are very few people doing it. We're very, very enthusiastic about it. So it's just catching up. So hopefully by the end of this year, this will have 2-3 public hospitals with stroke service, because the patients are there. There are a lot. There are a lot of patients who can benefit from this. And as a society that's agrarian, where people work in farms and do manual jobs, this is going to be a big help. Next. So ischemic strokes are common and they are devastating disease. Thrombolysis should be available to all patients, but mechanical thrombectomy is efficacious and it has good outcomes even in this country. And it's available. If there are 11 cath labs in the country, I think all of them should be doing stroke service, and that will improve outcome. Next. This was 2019 when I was still a resident, and I'm very grateful to the organizers of this for giving me the opportunity. Thank you very much. Next.
Thank you, Dr. Cullen. Anybody have any questions? I was hoping we would have some more residents this year to give some more skulls to. I brought one, but we'll save it for next year.
Of the 52 active neurosurgeons, how many do this?
Not very many, maybe 2, 3. Yes. Yeah.
Yes.
I just wanted to ask, like in this hospital, for example, in Kisumu, if there are stroke patients, what's the general protocol for that?
So it depends on where you are. If you land in Jaramogi, they probably have TPA, and you get TPA, and then you land in the medical ward, and that's it. You slowly wait for fate.
When the patient is brought,
yeah,
like paramedics or you give aspirin, is that a part of the protocol?
It's not very organized, so it depends on who's taking care of you. But yes, generally, yes. Yeah.
Yes, just one question. To Victor, the money, how much does it cost to, because I've had from my family, I've had stroke patients.
Yeah.
And I think just an angiogram costs about $7,000 to about $5,000. So how much does it cost for the patient? How much do they have to pay to?
So for the current center that is routinely doing this, for you to get a thrombectomy, a 2-3 day ICU stay will cost you around $15,000 to $18,000. So it's out of reach of most hospitals. But if you cost it directly, this can be done in a government hospital. That cost can come down to 3,000 to 4,000 USD from 18,000.
And the implants, how much is the implants?
So what do you need for mechanical thrombectomy? It's just the solitaire that's expensive.
Okay.
Yes, which is supplied by Medtronic. The rest of the things are easily manageable.
Hold on 1 second. Let me give you a mic.
Do you do the measurements?
Yes, we do this under general.
Any other questions? Okay, so we will move on to our next talk. Thank you so much. Oh, we have a question. We have a question.
Mine is simple. How does this August body systematically guide this region and the hospital like John TRH reach the level where it can do this? That would be the point of action.
Everything, like all this stuff costs a lot of money. So definitely in order, neurosurgery, like you mentioned, it's always been considered a luxury kind of service. But in order to provide this, because it costs money, it costs a lot of money to provide neurosurgical services. So in order to do a program like this, in order to get vascular, in order to get neurosurgery to the level that we want to get it to, it's not just a matter of, say, us bringing a drill here and there, but we've got to implement some kind of way that, okay, what are we going to do when the drill is broken? Okay, are we going to replace it? We need to have some kind of funding where even if you have a local neurosurgeon here, if they don't have the tools to work with, they can't do the procedures. So we have to have a way of keeping the funding going and keeping the neurosurgeons, or if you do have a neurosurgeon, I know in the US, a lot of times recruitment too, it all depends on what you provide as far as equipment. In order to do things, and the theme of our symposium, not only the theme of our camp this year was really focusing on quality. And in order to do quality work, okay, you need the right equipment. You need the right tools to do things safely. You need to make sure that the hospital has the adequate hemostatic agents to be able to control bleeding if you get into it. So I think that with funding and support from the government, with funding and support from the administration, that's how we're going to take this thing to the next level. Because we know we have the commitment from the surgeons. I think we have many surgeons who are willing to come and do the work. Is how can we do it safely and make sure that the patients we're operating on actually have good outcomes? And that's going to be with having the right equipment. All right. So here's what we're going to do. We're not going to take a break. If you want to, there's coffee outside. At any point, if you want to grab a coffee, please just grab a coffee and come back in. We are actually ahead of time. I know it seems like we're running behind, but we are caught up. This is our final talk, multidisciplinary approach to pituitary tumors. So let's just tough it out and finish strong. And if you need coffee, just step out, grab some coffee, and come back, please. Dr. William.
Thank you, Vic. Now, it is the last talk, so before we start, everybody just stand up. Reach for this. Right. Yeah. Yeah. My Apple Watch. You got this. You got this. Now, you may sit down if you want. If you want to go for coffee, so go ahead and go. Vic, I won't try my American. I'll speak my low English in this particular one. Yes, but it's very managing the pituitary tumors. I think the pituitary gland is quite an amazing organ. It's hormonally, it's the one that orchestrates. It's the one that drums everything. It's the conductor for what we are. It's the one for mood swings. It's the one for us to help make babies. It's the ones who help us grow and all sorts of things. So the pituitary gland is actually an amazing organ. Next slide, please. Those two people, they were mentioned earlier on, God rest their souls. The white man, Professor Renato Francesco Ruberti. In terms of bringing neurosurgery to the region, he used to work in Padua in Italy, came across on a hunting safari, and he fell in love with Kenya. When he fell in love with Kenya, he used to hunt with a gun. Then he started using a camera. So he went and sold his stuff in Padua and came and stayed in Kenya. Adoloy, they started with Professor Adoloy from Nigeria. They started the Pan-African Association of Neurological Societies. And in terms of burgeoning, in terms of how to connect us together, this was how things started off. Next slide, please. Go a bit further. Neurosurgery didn't just start now. Let's go back to Egypt. If you think about how mummification was done, they at least go to the nose. So endoscopic surgery was actually done then to aspirate past the brain and make sure your people are mummified. Next slide, please. In Hindu mythology, Ganesha, the son of Shiva, was protecting his mother Parvati. He was very upset, so he chopped off his head. But his wife was very upset. So he said, what you do, get that head back. My son, the only head available was that of an elephant. First head transplant. So neurosurgery has been going for some time, and it's all near the pituitary gland. Next slide. That gentleman sitting there or standing there with a kilt is Professor Graham Michael Teasdale, the co-author of the Glasgow Coma Scale. The one on the corner here, that's the one that killed speaking. This gentleman here is Sam Galbraith. They are the ones who co-authored the Glasgow Coma Scale, the paper that has been quoted in medical literature. It was written on the back of a cigarette packet outside Glasgow because they used to drink a lot of alcohol, and the best way to describe the coma was related to how much of alcohol you drank. Graham Teasdale was a stalwart in pituitary surgery. I had the privilege of working with him for about a couple of years. There was a time when he was very unwell, and we actually looked after his service. He's the one who introduced me to the idea of multidisciplinary pituitary work. Ophthalmologists would sit, endocrinologists would sit, neurologists would sit, neurosurgeons would sit, and they decide and manage how patients are done. It seemed very simple until I came back here in terms of what to do. And in those days, from working sublabial back to front, endonasal, and now we are using things endoscopic, transfemoral. Next slide, please. That's the teamwork. Kasam, who's well known for scalp-based surgery, gave you that thought about how, if you do things in a multidisciplinary manner, you can manage to get things done correctly. Next slide, please. Do you do it multidisciplinary or do you do it single-based? That paper actually described this very well. When they started doing multidisciplinary approach, less people were doing the surgeries. There was focus on two surgeons. They were able to improve their ability of doing things. It improved the outcomes, improved the fact that things were picked up earlier, and it worked better. Next slide. Now, I like Rose Gallery. In this picture, there are some people who are no longer with us. Professor Sande, one of the first neurosurgeons, Renato Ruberti, brought neurosurgery here. That's my classmate. God rest his soul. He passed on last year with a stroke. Talked about strokes. He was very fit. He was able to be exercising every day, but he had a floating plaque in his neck, and it obstructed. He ended up with malignant hypertension. Then he had other problems. But that group of people was at the beginning of COSEXA, trying to get stuff done. That group, I think here is Ben Wolf. Ben Wolf at that time was working in cure in Bali, and cure in Uganda. That was done at the Aga Khan. And all of those people, they were the beginnings of how we get multidisciplinary approach. Next slide, please. So those objectives. And this is the last presentation of the day, but we'll just run through some of these things. Next slide, please. There are 10% of the tumors, mostly in the third and fourth decade of life, and it can happen with multiple endocrine adenoma. The English escapes me if I say adenomatosis. I have to think carefully. Next slide, please. In the anatomy, why I think it's such an amazing organ, it sits there. Next to it, Khalif's favorite vessels, carotids, and this is what bothers us. When it increases in size, optic chiasm. Next to it, you've got the cavernous sinus. Next slide, please. And in terms of how to approach it, what really helps is you've got this space here, the sphenoid. All the cranial nerves are there, so you can imagine as it expands, you can go into the cavernous sinus, up there you can get the optic chiasm, and so on. As it grows, you can pick up all those things in terms of structure. So there is the endocrine problems, and then you have the structural problems. Next slide, please. This is a sagittal contrast enhanced one weighted image. There's the sphenoid sinus, there's a lesion. So in terms of a pathology, why go through the brain? Why there's an access route directly there to it? It's contrast enhancing. Next slide, please. Same thing, coronal view, sphenoid sinus, lesion there. Next slide, please. Now, you can have multiple areas of low density within it, and there's the optic chiasm just been seen right in the middle. So with that route there, route 1, you can get right into it. And you see, this one has actually beginning to invade in the cavernous sinus. So if you've got your multidisciplinary team, you would have picked up if there are any endocrine abnormalities, you would have picked up if they are hormonal, if there's visual disturbance. The ENT surgeon would have seen in terms of access, how do you get to it? Because not only getting access in the nose, how do you seal it afterwards? Next slide, please. All the different type of pituitary problems. Next slide, please. And other non-neoplastic disorders. Inflammatory disorders are also there. And the Khalif would be happy to know that they also aneurysms in there. They'd be very happy to coil it as opposed to having it opened because he does endovascular treatment. Next slide. In terms of clinical presentation, this is where the endocrinologists come in. Productive adenomas. We have a fair number of population who are infertile because of this in the ladies, and even in men, they have secondary sexual characteristics having a problem. Growth hormone, you get Janus hormone, thyroxine and gonadotropins, all of these things, you'll be picking them up endocrinologically. The mass effect, we've talked about the optic chiasm, how the people go blind, and that's a big presentation in terms of how people present. A lot of the patients that come to us from the ophthalmologists because they come to eye hospitals saying that they are blind. Why are they blind? They see they've got optic atrophy, and when scans are done, it shows that there's a lesion. Gland itself, cavernous sinus, you've got other cranial nerve abnormalities, and of course, if it's very large, you can end up with hydrocephalus. And if it's acute onset and they have a big headache, it may not be just a subarachnoid hemorrhage. The subarachnoid hemorrhage could be because of the apoplexy. Next slide, please. Now, a lot of us here who were trained locally had the privilege of working in KNH. And those were some of the earlier signs that we had of patients presenting with lesions within the cellar. That you can see that the 5-pointed star has been filled up by a lesion. Next slide, please. That's it taking up contrast, and Khalif would think that's an aneurysm. But, no, it was not. It was actually a meningioma. Next slide, please. But you can have lesions within the pituitary gland. And you can look at that looks like a mess. The retractor that we're using there is what we had before. It's the ladle retractor. I don't know Yashagil. Ladle. Self-retaining, hooked on the edge of the skull. That's a craniotomy flap. You'll be able to get in there. That looks quite a mess. But that's how you can get through doing the craniotomy. Next slide, please. That's what we managed to take out. Next slide, please. You don't have to have very elaborate images. That's a simple plain X-ray of the skull. Of course, in that you can see something got a big jaw for medicine. As well as that, if you look at the fossa is actually very large. Next slide, please. That was the MRI that was done, and you can see what was filling it up. Cottage loaf. Cottage loaf, you know, I mean, just makati, just cottage loaf itself. It's got a narrow bit and a bit on the top. Next slide, please. That's a coronal view, and you can see it's just abutting the optic chiasm. Next slide, please. That's that lady we've seen before. Signs of prognatism. She's got big features, lips. Next hand, please. Same thing, you can see lateral X-ray. Next slide, please. And those are hands. I think I've got big hands, but hers are bigger than mine. I wear size 8.5 and 9. The same for those of you who have been in medicine for long enough, there's a saying that they say, you know, what they say about men with big hands. Some people are getting shy here. No, they just wear big gloves. That's all. They just wear big gloves. Next slide, please. And those are her feet. Next slide, please. So evaluation, the history, visual field effect, and then endocrine function. In radiology, we discuss some of those. Next slide, please. So in terms of surgical treatment, once you make the decision in terms of what to do, transfemoral now is actually standard of care, more or less. You use endoscopic, especially for the intracellular, the macroadenomas. And if the tumor is extending the sphenoid, it makes it that much easier. But you leave the craniotomies for very large lesions, and if it's very fibrous, you can't get hemoglobin. Next slide, please. That is what Professor Graham Michael Teaser used to do. Microscopic transphenoidal, the big retractors, getting right in the center, and you have the lesion right in the center there, and have it decompressed using the curettes. Next slide, please. In endoscopic scalpel surgery, I had the privilege of starting from microscopic to translabial, working on through, and we have evolved, and at least where I work. So introduction of flaps, I now leave it to the ENT surgeons, otorhinolaryngologists. We are in Kisumu region, so the similar word is otobulo marengo dolorogy. For those people who are not inducted, otobulo is a 10 cent. And if it runs and goes around you, it actually goes, it stops. So otorhinolaryngology is otobulo marengo dolorogy. We have got introduction of flaps. The ENT surgeons are able to put the different flaps to heal even large lesions and new technologies. Next slide. This is the basis of getting through the nose. Learning the blood supply. That is where we want to get. And the flaps can be taken through the ethmoid, the stenoparts and artery, and those flaps can be able to get through, even if you decompression, you can put the flaps across to make it easy. Next slide, please. The ENT surgeon like a roadmap. That's a coronal CT scan. We are now spoiled because we don't only have the MRI, we do a CT scan, and we merge the two with image guidance. So we're able to see the anatomy before we start. Next slide, please. That's an example of what we'll be dealing with. Up-to-date MR, sphenoid sinus lesion being present, these areas of apoplexy. You see it pressing on the optic chiasm. Next slide, please. Now, this is where we are now. We were talking about technology earlier on. We are privileged to be able to do this at the Nairobi Hospital. Alif is there making sure we're doing the right thing. We've got an S8 Medtronic image guided system. We do bi-nostril two-surgeon technique. I had the privilege of working with many left-handed neurosurgeons, so I'm ambidextrous. So I actually stand on the left side of the patient, and my colleague, the ENT surgeon, stands on the right. So we're able to do so. And you can actually see us using the image guided system, and that's the X master spot. Next slide, please. And that's using the S8. Next slide, please. It's just a quick view of what it looks like. And mind you, here I'm standing on the opposite of the patient. And it's just that so my stomach and Professor Mashali's stomach don't meet and our knees don't touch. You can't have men touching knees. It's flat. So we're across the other side of the table. And that's the image guided system be able to show where it is. While loading, we've taken the flow off and speed. Yeah. We're just opening up there. And this was soft. There's an area of apoplexy. So once that is cut through, we'll be able to see it coming through there, decompressing it, and that's irrigating after. Let's put the next slide. That's by nostril forehand technique. Next slide, please. And that's what we managed to take out. Next slide, please. And the flaps are, we've actually been using flaps routinely, had flaps. I think it's an overkill, but thus far we don't have any CS technique. Next slide, please. And they don't end up having any crusting, so that's what the lesion looks like when you look up the nose later on. Next slide, please. So the complications, that's what we normally had, hormonal imbalance. Since we work with endocrinologists, hormonal imbalance is usually anticipated. So SIDH, IDH is actually, okay. The secondary empty cell syndrome can actually occur if you take too much of it. Hydrocephalus is very rare. Infections is one of the complications. CFS or rhinorrhea, we hardly had any of that. Carotid rupture, thank God, thus far we have not had any. And then you can have a covered sinus breach and nasal septal perforation. All this can be secured. Next slide, please. This is where the ophthalmologists come in. You can see this time and time again, visual failure. Before, after, right and left side. Next slide, please. Before and after. And patients are so happy. They go in, they cannot see. The next day you're walking in the room saying, oh, Dr. I can see you. It's one of those gratifying things. Next slide, please. So, craniotomy complications could be those ones. Next slide, please. And the EMA approach. Now, all of those ologists, radiologists, endocrinologists, ophthalmologists, Johnson. Now, what we don't have thus far is a combined approach. What we are hoping to be able to do now is we actually have simple clinics where all of us interrelate. But what happens is they see one after the other. It takes a bit of time, but we make sure that we have things done. Next slide, please. And that just gives a diagram of how it is we work. If you have a lesion, if it's persistent growth, if the hormones are imbalanced, you can work your way through after the radiation treatment. Now have gamma radiation across at KU. So worrying about the optic chiasm is less. Next slide, please. So that's why we've had those. Fortunately enough, that's why only 33 endoscopic endonasal lesions. Most of them have been prolactinomas, female ratios like that. Next slide, please. And the majority of them had visual improvement. And that's what really one of the stalwarts of what you want to do. Next slide, please. So follow-up, history and examination. So I think for the residents, the history, how they are presented, if they are having engorged breasts, or if they're having reduced secondary characteristics or visual failure, follow up on the history. Hormonal, check the levels. Optometry, make sure the visual assessment is actually done. And the radiology, 3 months, 6 months, a year, follow them up. Next slide. Those are our challenges. Late presentation, people come in when they are blind. The cost of treatment, we keep talking about costs, show the money, people say. The learning curve, investment in equipment, money. Radiation therapy now, we had a problem before, but we've got more focal methods of treatment as we have in KU or RTH. And the concept of multidisciplinary teams is actually developing, which makes a difference. Next slide, please. So medical treatment, carcinomas, we have people who have had treatment for at least 10 or so years. They managed to get babies following it with Dostonics and so on. And medical treatment, the endocrinologists follow these things out. Next slide. So increase the awareness. Send all the PGTs to me so I can do more, please. And then collaborate with other centers, guys across, abroad, etc. And the trainees, people who are interested in it, make sure we do so. We've had workshops locally to be able to extend things. Next slide, please. No, that's a work image. When I was young, I used to run fast, but not as fast as the Asian ball. Next slide, please. Now, I like putting that up because have you ever been in Nairobi or in Kenya in July, no, in September, October, November? If you have, that's a jacaranda flower. Very beautiful. It's got nothing to do. Guess what I put it up there for you? So I like the color purple, nothing to do with the movie. But it's a good picture to end with. Next slide, please. And I'll say thank you very much.
Thank you, Dr. Ogunya. Any questions? Any questions? It's as clear as mud. With that said, that's the conclusion of the third annual Kisumu Neurosurgery Symposium. I hope to see you all next year. Thank you so much. I'd like to thank the faculty for being here, the organizing committee, thank you so much. CEO, Dr. Wright, for being here, thank you so much. And all of you attendees for making this possible. So it's great to have each one of you. So now put it in your calendars next year around the same time, start taking your time off. And we're looking forward to a great symposium next year as well. With that said, is there any comments? Did everyone?
Thank you, Dr. O'War, for putting it. Yeah.
We have a program director.
Yeah, thank you, Victor. I thank you, and I thank everybody who is here. This is the 13th neurosurgical or neuroscience camp. 2,000 patients were actually screened, and it's becoming a tradition. It's gone wide into the country because people are coming all the way from Mombasa, from Nyeri, and it's offering a model which is not anywhere because the history was that you either go to Nairobi or you don't go anywhere else. But you're changing history. That this is becoming a center for learning, a center for service delivery, a center for thinking, and a center for asking questions, basic questions. And if I or anybody extrapolates this into several years to come, it would have a very romantic history of where you started. And you kept what we call a faculty which is in the move through and through. And I think great things are going to happen. Even the removal of pituitary, we may have newer methods of doing that, which is generated from this place, with people giving new ideas on how to do things. But on behalf of our governor, I will extend, and I'm sure he'll be here to meet you before you leave. I say a lot of gratitude and a very humble request that this should continue and involve more people.
Thank you. So tonight, what time is it?
3:18.
3:18. So at 5 o'clock, I would like to. There's an after party. So now we're going to go to Dunga Hill Camp for the evening. So for anybody who is here, please join us there around 5. We're going to watch the sunset and listen to some music. My cousin is performing, so come on out. From the Creative Band of Kenya. So come on out and let's go to Dunga Hill Camp. Wait, thank you. It's not far. It's not far at all. It's
down the block.
It's down the road.
Here we did it.
End meeting. Bye, guys.
See you never.